14th of November, which is actually the Bavli on that particular day. So we have arranged this CME on 7th of November on occasion of World Diabetes Day. And diabetes is actually not a illness, but it is mother of all illnesses, and it is very commonly associated with heart failure, as we'll know in our presentations. So we have first of all, we have kept a panel discussion on heart failure, the nemesis of diabetes. And our panelists are Dr. Abhishek Shukla, who is an interventional cardiologist, and he has done his DM cardiology from Rajasthan University of Health Sciences Cardiology Center, and he has an immense experience in diagnostic coronary angiography with more than 10,000 procedures, both from radial and the femoral axis as primary operator. He is awarded with many certificates of appreciation in invasive cardiology and awarded with gold medal in MD General Medicine from GSPN Medical College, Kanpur. MBBS he has done from KGMC, and he has specialized in angiography, angioplasty, pacemaker, ICD, CRT devices, balloon, mitral valvotomy, and peripheral vascular angioplasties. Our other panelist is Dr. Ajay Belia. He is senior consultant, and he was my senior at Metro Hospital Faridabad also. And he has more than 18 years of experience in field of cardiology. He has done more than 15,000 procedures, including IABP, pacemakers, and then endovascular procedures also. He is expert in invasive as well as non-invasive ventilator procedures, extensive experience of working in cardiac intensive care. He has 7 publications in peer-reviewed articles. Then he is principal investigator in various clinical trials. He is advisory board member of various companies and a regular speaker for different companies as well. So, starting with our panelists, we will be having co-chairpersons also, who is Dr. Sanjay Kumar. He is HOD CTBS. Dr. Arvind Kumar Pandey. He is associate consultant. Dr. Brij Mohan. He is director of the HCG group of hospitals. Dr. Rahul Singh. He is associate professor at UN Mehta Heart Institute, Ahmedabad, and many more people will be joining very soon. So we'll start our panel discussion without wasting our time, because already we are 15-20 minutes late. So seeing the heart failure problem in India, we have to know what actually the heart failure is doing bad to us, and it is currently the burning topic, and it is very important to discuss this topic, as we'll see in our future presentations. So is heart failure so important in Indian scenario? So this is a report from US, and it shows that actual burden of the heart failure is far more than what is projected at different interval of time. Like in 2000, the projection was almost 3.5 million cases, and in 2020 the projection was almost 80-90 million people, and but the actual problem is far more. So the mortality rate and the comorbidities associated with this, the mortality rate of heart failure is almost 50% at 5 years time, whether it be a heart failure with reduced ejection fraction, whether it be heart failure with preserved ejection fraction. Heart failure with reduced ejection fraction is slightly easier to deal, because we are knowing the cause, we are trying to treat that cause, neurohormonal mechanisms are there, some of the new drugs have arrived, but heart failure with preserved ejection fraction is far more difficult to treat. and the burden is rapidly increasing by year 2030. The number of the patients would rise by almost 25% in 10 years' time. So, even mild to moderate patients are at high risk. The patients who are in NYHA class 1 or 2 and the patients who are in NYHA class 3 and 4, they have slightly more mortality of around 40%, while the class 1 or class 2 patients have a mortality of almost 33 to 34% is seen in clinical trials with a follow-up of almost 3 years. So in Indian scenario, what we see that there are repeated hospitalizations, and it is true with the global data also, that hospitalizations are common after heart failure diagnosis, and it is almost 43% uh, 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 patients are hospitalized at least 4 times in a year, and almost 30% patients are readmitted within 1 year time. The mortality is almost up to the tune of 45% at 3 years. There are multiple comorbidities associated, like diabetes, which is increasing the mortality of heart failure in almost 34% patients. COPD is very commonly seen in patients that it increases the mortality by 40%. There is renal dysfunction, cardiorenal syndrome, which is almost present in 50% of the patient. This increases the mortality by 3 to 4 times when the patient is having history of MI or having hypertension and hospitalized. With this background, I would like to put the first question to Dr. Abhishek Shukla, that there are some conventional drugs available and they are effective also. We cannot say that they are not effective, used for heart failure, and it also improves the survival. So, what is the need of a new class of drug for management of heart failure? Dr. Abhishek, I'll be running the slide from this side,
Okay,
and you can just present yourself. And when you need to change the slide, you just tell me. I'll be changing the slides. Okay.
okay. Thank you, boss. First of all, I like to thank you for your kind words in, you can say, my brief introduction. So, this is a very important and burning topic. You already said that heart failure, as there is a lot of, you can say, for a long duration of time, since decades, we are working on heart failure. There's so many studies, there are so many drugs that have been tried, and this era has started from the use of diuretics and digoxin, and now we have a newer things on board like ARNIs. So if we see where we were, so in the era of diuretic and digoxin, there are very less studies, so we do not have very good data to suggest the mortality. But with the advent of AC inhibitors, beta blockers, the more understanding of heart failure comes in, and we start establishing the mortality reduction, we start establishing the rehospitalization issues, and we analyze that AC inhibitors reduces the relative risk of mortality by 16% and absolute risk reduction is around 4.5%. If we look at beta blockers further reduce it by 34% and absolute risk reduction is 5.5%, and this is all up to 2000 what we were knowing and what we were using. Later on, we have another thing on board that is MR antagonist. This has come up with a newer understanding of renal aldosterone axis, and we analyze that yes, further 30% reduction of mortality is there and rehospitalization reduced were there, and this is all backed up with the very landmark trials, and these are the very good trials with lot number of patients. Now, up to 2000, you can say up to 2006, we understand that yes, MR antagonists are good and can be prescribed and should be prescribed as a class 1 indication. But still, we are lacking on board. We are lacking because the mortality of heart failure is still very high. The rehospitalization rate is still very high. That causes you can say it makes us more inquisitive that why these things are occurring, whether we are handling some of the system or we are not handling some of the mechanisms which we actually do not know. So later on, there are many more, you can say, studies at biochemical level, at stem cell level, and we will get to know there are certain more newer pathways that need to be addressed in order to reduce the mortality. ARBs are used in the CHARM study. This is specifically candesartan was studied, and it also shows similar to ACE inhibitors a good reduction that is around 17%. And later on, we analyze in this is the era of 2010 when we start analyzing that heart rate and heart failure. These go hand in hand. If your heart failure patients or chronic systolic heart failure patients have a higher heart rate, it will increase its mortality. Now that comes the role of there comes the role of ivabradine, and ivabradine has proven itself in reducing the sinus rate of these patients and later on reducing the mortality of these patients by 19%. So if we further go on analyzing with the all drugs that are on board, still we are not up to mark with the heart failure management. Next one. So now the question arises, we know the sympathetic nervous system, we know there is a role of epinephrine, norepinephrine, which results in vasoconstriction, increased renin-angiotensin excess, vasopressins, increases the heart rate, increases the contractility. Now, this is all detrimental for a failing heart. So we understand, we impose a beta blocker and we start addressing this issue. Then comes the role of renin-angiotensin system. We know this system, it causes vasoconstriction, it causes a rise in blood pressure, sympathetic tone will be high, and aldosterone levels will be high, resulting in fluid and water, sodium and water retention. But one of the most important thing, what we understand with the renin-angiotensin system is the cardiac remodeling. Now, what do we mean by remodeling as a cardiologist? The change in the geometry of the heart that results is inefficient work. Now, inefficiency usually results in term of uh, if we just impose it to clinical system, that it means a reduction in cardiac output and hypoperfusion state. So this inefficiency usually results from a inappropriate hypertrophy as well as fibrosis, and this is all component of a renin-angiotensin aldosterone axis. So this is what we were knowing, and we are addressing these two. But there is a one more system that is known as lepri-lysin system or natriuretic peptide system. We have three good natriuretic peptides, that is ANP, BNP, and CNP, and these natriuretic peptides are having a favorable impact on the vasculature as well as cardiac remodeling status. Now, if we see what does these natriuretic peptides do, they causes a reduction in blood pressure, they decreases the sympathetic tone, increases natriuresis, vasopressin reduction is there, and ultimately they are causing a negative feedback on the renin-angiotensin aldosterone axis and hence preventing the remodeling. But there is an enzyme known as neprilysin, and this neprilysin disintegrates the natriuretic peptide. So this is one more pathway we get to know. Although we know it for 5 years, but we were not very helpful. It was not very helpful. You can say we have not very good data on or studies that come up with good results. But later on, with the advent of paradigm heart failure studies, we get to know that yes, if you inhibit the neprilysin, then increase in natriuretic peptides have a good favorable outcome, and we will discuss it later on. Next one. So if we see when we combine these two things, one is a neprilysin inhibitor in order to increase the level of the natriuretic peptides in the bloodstream, and a renin-angiotensin receptor axis blocker, that is a valsartan. So when these two things were combined, the results are drastically better. They causes a significant reduction in mortality to the tune of around 20%. And this data is from the paradigm heart failure study. And if we see salt from the salt treatment, AC inhibitors causes a nearly 18% reduction, and ARBs causes a 15% reduction. Next, please. So if we further analyze this data with the use of uh, basically comprehensive therapy. Now, this is a very latest study that is published in July 2020, and this study is basically uh, the analysis of different trials that are presented. Although we have to analyze it carefully, but yes, it is all landmark trial of heart failure, including SGLT2 inhibitors like dapagliflozin, ARNIs, like paradigm heart failure. So, considering the conventional regimen of you can say ARBs as well as conventional regimens of beta blockers, MRA, if we add on all these newer molecules on board, that is a ivabradine, that is a ARNI, that is a basically uh, dapagliflozin, even in the patients of diabetes, non-diabetes, the cumulative results were significantly favoring the comprehensive therapy. That means whatever we are using conventionally since long, it is now better to use a comprehensive therapy with newer molecules on board to prevent a to cause a greater reduction in hospitalization, rehospitalization, mortality, and basically all cause mortality. Next one. So basically, if we analyze this, how much this will help if we go on to giving a comprehensive therapy that is best tolerated or a guideline directed therapy. So if we see the event-free survival in the patients extending from a lifespan of 55 to 90 years, these are the age of the patient which are analyzed in this trial or analyzed in cross studies of this trial. They found that there is a 8.3 years difference that occurs in the arms of conventional and comprehensive. That clearly shows the benefit of event-free survival, and every event-free survival imposes a better, you can say, quality of life as well as a lower risk of rehospitalization, and yes, in India, a financial burden that is also reduced to these patients. Similarly, if there is another analysis, or this is also from the same publication, and that is on 65 from 65 years to 90 years, the results are nearly same. It is the graph expands very early. So, initiating the comprehensive regimen that includes ARNI, either if required SGLT2 inhibitors, and all conventional regimens on the background, that will be highly beneficial. So this is the reason why we need more therapies to address the issue of mortality. Thank you.
Amit sir, you are on mute.
We all know that there are classical drugs which are very helpful in management of CHF, but still the mortality and the rehospitalization rates are also very high. And the hormonal mechanisms which are actually working behind the heart failure and which are actually deteriorating the patient's condition are actually not managed by our traditional drugs. So we need something new. So since it is all about diabetes today, so what is the role of diabetes in heart failure, disease progression, and clinical outcome? This is my question to Dr. Ajay Belia. Dr. Ajay?
Thank you, Dr. Amit. Yeah, you can hear me?
Yes.
Yeah. So basically, diabetes and heart failure are having a bidirectional relationship because we all know that diabetes is the root cause of cardiovascular diseases, and if diabetes is not appropriately controlled, then it may cause cardiovascular morbidity also. So it is basically a bidirectional relationship, and risk of incident heart failure is almost 2 times higher in patients having diabetes as compared to non-diabetic patients. So 2 to 2.5 times higher in individuals. So risk of incident diabetes in patient is also around 1.5 to 2 fold higher. So basically, they are all interrelated. Patient having heart failure may develop hyperglycemia. We'll be discussing later on later presentations that how the present scenario, the COVID scenario, has caused newer emergent diabetic patients, and what is the root cause, what is the reason behind patients having hyperglycemia or patients developing newer diabetics. The patients who were not diabetic, they are now having diabetes. So if we talk about diabetes and heart failure only, so diabetes, insulin resistance and endothelial dysfunction, it enhances hyperglycemia, which causes coronary artery disease or may cause myocardial infarction, and later on it may cause LV dysfunction leading to heart failure. Next slide, please. Next slide. Yeah, diabetes. It. Sorry, the previous one. Uh, it causes deterioration in 3-4 ways. Diabetes itself is a low-grade inflammatory process. Diabetes associated with obesity, dyslipidemia, endothelial dysfunction, um, uh, encourages coronary artery diseases, which in later on may cause ischemic cardiomyopathy. And itself, the cardiomyocytes itself they are so much soaked in hyperglycemia that they themselves they fail to work properly. So that may lead to diabetic cardiomyopathy. Uh, Excessive activation of RAS system, and which leads to fibrosis, myocardial fibrosis, and leading to cardiomyopathy. Changes in calcium handling and changes in fatty acids utilization, formation of advanced glycation and products, plus autonomic dysfunction. They all lead to diabetic cardiomyopathy and may later on cause heart failure, which we may label as a heart failure of diabetes. Next slide, please. Also, most of the studies they have shown the increased risk of heart failure as compared in patients having diabetes as compared to patients who are not diabetic. So, Framingham Heart study showed a relative risk in men up to 1.8 times higher, relative risk in women up to 3.7 times, cardiovascular. So all these studies they show that the relative risk or the hazard ratio they tell us that a patient having diabetes has a higher risk of
Dr. Ajay, you are not audible.
I'm not audible. Hello.
Now you are
Now
audible.
you are, now you are audible.
Yeah, next one.
Okay.
Also, diabetes also increases the risk of hospitalization or death due to heart failure. Almost we can say if we follow up patients, there's a slide showing follow up of patients for almost 3.5 years. So patients who are non-diabetic are having lesser incidence of hospitalization or death due to heart failure. Next slide, please. Also, heart failure with preserved ejection fraction, if we see the incidence of hospitalization or death is markedly higher in patient having diabetes. Next one, please.
Okay. So, as we all understand that heart failure and diabetes are both syndromes, and they lead to multiple complications, multiple risk factors, and we as a clinicians, as a doctor, as cardiac doctors, we need to address each and every issue with the patient, not even the symptoms and signs, but also the financial issue burden and everything. So my next question is to Dr. Abhishek Shukla that what is the available data of initiation of medical therapies in hospital settings for heart failure with reduced ejection fraction? And what are your comments on the safety profile of that new drug ARNI or sacubitril valsartan while initiating it in ADHF patients? Dr. Abhishek, you are mute. You have to unmute yourself.
Okay, now I'm audible.
Yes.
So first, let us discuss on certain evidence and what evidence we are actually having. If I say very clear that actually we don't have any good evidence in acute decompensated heart failure until late we have ARNIs on board. ARNIs have changed our practice and ARNIs have changed even the understanding as well. Though they have come up with a very good data of acute decompensated heart failure. But let us reanalyze or just go back and see what AC inhibitors or ARB do we have real data on acute decompensated heart failure. So if we see there is no well organized randomized trial until late when they are compared with the ARNI, in that case we have a good data on AC inhibitor on acute decompensated. Otherwise we do not have in the back. If we see MR antagonist that has come up and these are part of guidelines from 2008 onwards. MR antagonists, they were studies in acute heart failure, and these are basically 685 patients. And this study has basically shows the importance that initiating a MR antagonist therapy late in the discharge, that means 30 to 90 days post discharge, is associated with increased mortality as compared to the when the therapy was initiated in hospital. So this shows the importance of initiating the therapy in the early course of event, preferably in the acute decompensated state. If we look at beta blocker, again, though we have a good open label study of impact HF, but the number of patients are less, despite of having very good evidence in chronic systolic heart failure with huge data, we have very less data for the beta blockers in acute decompensated state or patients with acute heart failure. So that gives us the rider that we always initiate these drugs when the patients are out of CHF, they are stabilized. But if we see the impact heart failure and see these 363 patients, it is observed that if you start beta blockers more than 2 weeks after discharge, these patients have lesser benefit as compared to the patients in whom it is started earlier. And this is associated with the lower risk of rehospitalization as mortality. No, this is all is backed up with the data, or you can say our understanding that a patient of acute decompensated heart failure is at very high risk of rehospitalization in the initial 30 days. Now, this is very important for us to address the timeline and to the intervene appropriately. Next. So if you look at sacubitril valsartan, as I already told, we have a good evidence of initiating this drug in acute decompensated state in hospital setting when your patient gets stabilized before discharge. Next. So what do we have? We have very good trials. These are considered to be landmark trials. One is a pioneer heart failure and one is a transition study in patients of acute decompensated hospitalized patients. So these two studies have a very you can say a very good evidence both in terms of objectivity, that means with the evidence of anti-proBNP, and subjectivity, that means in terms of symptomatology as well as the rehospitalization. Next. So, so if we just see this objective evidence from the pioneer heart failure, so if you observe this graph, which is there on the left side of screen, we are addressing the change in NT-proBNP. NT-proBNP is indirectly related to the wall stress. So lower the wall stress of the left ventricle, lower will be level of NT-proBNP. So whenever these drugs were started in the early period, in the initial first week, there is significant 50% reduction in the NT-proBNP level, which goes on further, continue. It remains static for a period of 4 weeks and then again goes on reducing. Now, this initial 4 weeks, if you look at this graph, NT-proBNP remains stable. This is the time where there is a very high risk of rehospitalization in the initial 4 weeks. Later on, there is changing in mechanics and the hemodynamics are changed, and drugs are becomes very effective, and that will decreases the risk of rehospitalization. But yes, the risk of mortality remains the same. So if we see enalapril in same as the composite endpoint, so if you analyze these things by days, so when you start the things early sacubitril valsartan, you will achieve a composite endpoint of cardiovascular, you can say mortality, all cause mortality that is, and hospitalization. If you see both in the AC inhibitor arm, optimally managed, it is 16.3, and the sacubitril valsartan arm, it is 9.8. Now, this data just touches the significance, and it causes a, you can say, 42% reduction in the serious composite endpoint. Or now this has importance that you intervene early and you will have a good results with the ARNI as compared to the AC inhibitor. So if we see the cardiovascular death and rehospitalization, which is again an issue in the first 3 weeks, if you look at the graph from the initial 7 days, the graph starts diverging. That means you are not only reducing the mortality, but yes, you are also addressing the rehospitalization in these patients if you are addressing the ARNIs early and before discharge to these patients. Next. Similarly, the rehospitalization for heart failure, we know that there is 39% reduction in rehospitalization with sacubitril valsartan compared to enalapril. Now, all these points were very well addressed, and it shows that we have a very good data that suggests before your patient is discharged from the hospital, you should add ARB along with a neprilysin inhibitor, that means a sacubitril valsartan, to achieve an optimal result. Now, this I'm just addressing only this ARNI here because we are having a good data with this, so we are presenting this. Otherwise, rest of the conventional therapies are also should be on board for the treatment in these patients. Next. So if we analyze all these data and we see the recommendations, so now this is considered as sacubitril valsartan as a first-line therapy in patients of decompensated heart failure. So you have to initiate ARNIs rather than AC inhibitors in patients of new onset heart failure or decompensated CHF to reduce, if we say in single word, to reduce the all adverse outcome and mortality. And you have to initiate on the first line in order to avoid a need for titration of AC inhibitor or switching to a valsartan therapy. Now, this is basically initially what we are when we have treatment for chronic systolic heart failure. We have a run-in period, and that was just very initial part of this drug when it does came in the market. But nowadays, we very well start these drugs in the basically lay patients. Next. So if I summarize my point that there is no need to titrate ACE inhibitors, which were previously we thought of and we did also. It is not required to check plasma concentration of NT-proBNP prior to initiation of sacubitril valsartan. It is not required at all. So you can start the sacubitril valsartan. And we are also using in our acute decompensify address my own practice. So we usually start this drug when the patient is hemodynamically stable and your patient is basically at least not on very high doses of diuretic. In these patients, you can very well start with less complications. Next. So if we see, now the question arises, this was basically initially when this drug comes with chronic for chronic systolic heart failure, this was always addressed or it was always imposed that it causes a higher symptomatic hypotension. So when we analyze the paradigm heart failure, it causes a 12%, you can say, patients with hypotension, and only symptomatic hypotension was very less. But we have understanding that there is a hemodynamic instability or uncertainty in patients of acute decompensated heart failure. So if we look at the data of safety events, the worsening of renal function, we address hyperkalemia, we address angioedema events. If we analyze all these things, then though the numerically the numbers you can see are higher in sacubitril valsartan group, but there is a no significant difference in both the arms. So as the numbers are numerically higher, that only tells you the importance of analyzing or importance of observing these events rather than refuting the use of this drug against the enalapril, which is again uh, causing the similar types of you can say uh, safety outcomes, or you can say adverse outcomes with lesser reduction in mortality and rehospitalization. Next. Now, this is all of the adverse event graph, that is a tabular representation of over a period of time of less than 3 months, 3 to 6 months. How does these drugs behave? If we see, although it is a very busy slide, but let me tell you, if you analyze all these things together, you can very well see that there is a no significant difference in symptomatic hypotension in the patients over a period of 3 months to 12 months in the enalapril and sacubitril arm. So sacubitril valsartan arm again have a numerically higher values. I am not denying that, but that does not reach the significance. And if you see elevated serum creatinine levels, it is again always the ACE inhibitors tops over that. Again, numerically higher values are with ACE inhibitors, but we cannot blame it. Both the drugs have almost nearly same episodes. So you need to be cautious with hyperkalemia more than 6 millimole or milliequivalents. If we see drug discontinuation, it is nearly same in both the groups. That means drugs are good tolerated between the two arms on both the arms. If we see dose reduction, yes, though there are many patients in whom dose reduction is there, but it is also comparable in nearly same in both the groups. And this dose reduction is related to the blood pressure effects, and average daily dose what is achieved when you analyze these things are nearly 85 to 100%. Now that means both drugs are equally you can say used. None of the drug is underdosed in order to have a better result. Thank you.
So, uh, as rightly said, that Arni is a very good drug for both ADHF and as well as de novo patients of heart failure if started correctly, and if the patient selection is good. So my next question to Dr. Ajay Kumar Belia is, what are the treatment options for diabetes management in a patient with heart failure? And what is your opinion is the role of ARNI in heart failure with diabetes? Doc- Dr. Ajay?
Slides, please. Slides. Hello. Yeah. So here we can see that at every level of the stages of heart failure, be it stage A, B, C, or D. So every level we try to control blood sugar, but it should not be very tight control in patients who are suffering more. Like stage D, we can be bit lenient with the blood sugar control, because as we try to control blood sugars tightly, the risk of going them into hypoglycemia plus the going into heart failure, the risk increases. So we should judge the sugar control by patient's clinical status. Patient should be able to manage their diabetes by themselves. Social support should be available to patients, and we should also look at the medical side effects and the cost of medicines, uh, and plus also the cost of hospital admission if the patient so requires hospital admission also. The risk of hypoglycemia should also every time it should be in our mind, and we should also see the burden of treatment we are imposing. I mean, definitely we have to give certain treatment, but we should also look at the patient if he is able to support or sustain that treatment or not. Next slide, please. See, every anti-diabetic agents have differential effects in heart failure. So glycemic management in patients with heart failure, they also differ. Regarding insulin, basically it can increase the heart failure admissions because it's a powerful sodium retaining hormone. And if it is combined with reduction in glycosuria, it may exacerbate the fluid retention, thus causing acute decompensation. And there was a study of 16,417 patients with diabetes and a primary diagnosis of heart failure, and it did not reveal any association between use of insulin and mortality. Regarding metformin, it's a time-tested drug, and it has shown to reduce mortality in patients with heart failure and diabetes. And it can be used only if the EGFR remains above 30 milliliter per minute. And basically, it should be avoided in patients who are unstable or hospitalized, because these kind of patients they are into risk of developing acidosis or ketosis. Sulfonylureas definitely they are associated with increased risk of worsening heart failure, risk of hypoglycemia, and they should be used with cautions. These they are not good as regarding heart failure patients, because they cause sodium retention and fluid retention, and fluid retention in it may provoke heart failure or worsen decompensation. So these class of drugs they should be totally avoided in patients who is having heart failure. GLP analogs, they are very good, like short-acting lixisenide, and it was proved to be safe. Uh, Looking at liraglutide and very long-acting semaglutide, they also reduce cardiovascular events in small randomized studies. Liraglutide, however, did not improve clinical outcomes or LV ejection fraction. DPP-4 inhibitors, they are again very good class of drugs. They they are free of free from causing serious hypoglycemias. Only saxagliptin was associated with increase in heart failure, which was not seen with other DPP-4 inhibitors. SGLT2 inhibitors, they have recently been categorized even in non-diabetic patients also, and they show significant reduction in composite ME. With AMPA and canagliflozin, both SGLT2 inhibitors reduce heart failure hospitalizations, and the risk of cardiovascular events, they are faring better in that way. Next one. Diabetes with heart failure, ARNI, they have beneficial effects because they are causing uh, like 81 receptor blockade and neprilysin inhibition, which helps in increasing natriuretic peptide, increases bradykinin, increases GLP, improves skeletal muscle and cyclic GMP, also decreases DPP4 activity. 81 receptor blockade, again, it causes increased insulin sensitivity. So definitely the combination, the ARNI, is helping in diabetic part also. Next one. So this combination ARNI, it enhances glycemic control in patient with in patients having diabetes with reduced ejection fraction, and HbA1c reduction was persistently significantly greater in patients who are receiving this combination uh, versus enalapril over 3 years. Next one. The time to initiate insulin also, there is marked improvement by 29%. We can see 29% reduction in new use of insulin in patients who are on ARNI, and if we compare it with the enalapril group, there's definitely better as it enhances glycemic control in patients with diabetes with reduced ejection fraction. Next one.
So sometimes it is very difficult to understand that diabetes has induced heart failure, or heart failure is inducing new onset diabetes. And drug like ARNI can reduce the initiation of insulin, which is actually, I think, the best thing to treat diabetes. But still, it is very hard for a doctor to make this thing understand to a patient. So, if a drug is reducing the use of insulin in patients, then it is, I suppose, a good drug. So my next question to Dr. Abhishek is that how often do you see the heart failure patients with symptomatic hypotension?
Okay, now this is a very important issue, and this remains an issue in the management of heart failure, hypotension. Any systolic blood pressure less than 90, we consider this as hypotension. So basically, if we analyze heart failure patients in terms of hypotension, there are two broad groups. One is the patient in whom the blood pressures are reduced. These patients usually remain asymptomatic, have symptoms of orthostasis. These patients have subtle hypotension. If we see the patients who have symptomatic resting hypotension, these patients who have usually the blood pressure, strike blood pressure less than 80. So I told you initially when the RNs were given, it was analyzed that 10 to 15% of the patient develop hypotension. That is a systolic blood pressure less than 90, but this is a numerical value. Some patients do have this very high level of stability and asymptomatic status at even 85 systolic pressures. So when the symptomatology was analyzed, it was found that only 2 to 2.5% of the patient really have a symptomatic hypertension reduces that requires a dose reduction or requires a stoppage of therapy that causes a lowering in blood pressure. So if we see ARBs and neprilysin inhibitors in terms of hypotension, yes, they do cause hypotension, but let us analyze the other drugs. So first important drug is the AC inhibitors. Now, if you see analysis, if you see these three graphical representation of underdosing and graphical representation of patients who have hypotension related lesser drug use, or you can not drugs are not used, it is applicable to almost all class of drugs, that is ACRB group, beta blockers as well as the RB. So this emphasizes that hypotension is the issue that is always there with heart failure patients, and this is the basically one of the most important reason for non-prescription of underdosing of guideline directed medical therapy. But if we see that AC inhibitors, beta blockers, and ARNI, nearly the numbers of non-prescription or less doses due to hypotension or adverse event are nearly same in all the groups. Next. So if we analyze hypotension in these patients, so hypotension is basically an indirect indicator of a severity of disease. Let us think this way. If your patient is a case of heart failure with reduced ejection fraction presenting to you with hypotension, drug related, non-drug related, both. This is basically an indicator of a severe form of illness which results in modification of your therapies. That means you are not able to optimally use your therapies, resulting in a further poor outcome, resulting in a further poor cardiac status or remodeling status is enhanced, and that will further result in inefficiency of myocardial function and results in hypotension, and this vicious cycle is going on. So hypotension usually by saying this, it means a part and parcel of heart failure with reduced ejection fraction, and we surely do not always curtail our therapy addressing this issue. Next. So before understanding hypotension, let us understand why this hypotension occurs in these patients. We know that is renin-angiotensin, aldosterone excess, beta, the autonomic nervous system, all these causes us vasoconstriction in the patients of heart failure, and this vasoconstriction is detrimental. Any vasoconstriction causes a higher lateral wall stress, and this any lateral wall stress that is high results in a higher degree of blood pressure. So if we see, whenever you counter this action, there occurs a vasodilatation, and whenever the vasodilatation occurs, the blood pressure lowers down. It antagonizes the effect that was there in the patients of heart failure, that is a wall stress. How the wall stress is reduced? By vasodilatation, the preload is reduced, the afterload is reduced, and that causes reduction in wall stress, and the efficiency of the heart is improved. So here I'm not just telling that hypotension is nothing to bother. Here I'm just emphasizing that hypotension is one of the most important part of treatment therapy, and you can very well see every now and then your patients of heart failure presenting with for few weeks of lower blood pressures, though remain symptomatic. Try to think of some of the medication that can be curtailed off, which do not have a good long-term outcome. For example, by saying so, I mean a diuretic. So whenever you address a patient, you have started a ARNI, start with the low dose. Whenever you come up with the up titration of dose, you are bound to address a hypotension. So whenever you address a hypotension, first look that you are going to reduce the diuretic. If you are able to reduce the diuretic requirement of this patient or diuretic doses of this patient, you can very well address the issue. You can very well reduce the doses of all the drugs that causes a reduction in mortality, preferably beta blockers. And later on, if nothing will work, then you are left over with only MR antagonists that can be given in the patients of hypotension. if your patient is basically remains symptomatic. Sometimes we have observed that these hypotension will remain for a few days in the initial part of the therapy, and later on when you either uh, subtitrate these drugs or down titrate these drugs, these patients get stabilized, and later on they can very well tolerate even the higher doses. So if we see the underdosing is very common. Underdosing is very frequent in patients of heart failure, and the most important thing is hypotension. My always advice to everybody: just understand the concept of hypotension, understand the severity of hypotension, understand your patient symptomatology of hypotension, and this will help you in addressing the drug therapy, and this will help you not to curtail the important disease modifying agents. Next.
Symptomatic hypotension is actually important, and what we usually see is that when we initiate with a drug like arni during the initial period, what we see is that there is some or the other amount of hypotension which is always seen. But what we should try to do is that we should find an alternative way to reduce the diuretics and other things, so that we can give space to a drug like arni. And then what you see is, after some time, say after 1.5 month, that when heart failure component of the patient is taken care of by arni, then this hypotension weans off slowly, and patient maintains a good blood pressures, and we tend to achieve guideline directed medical therapy or optimal medical dose of arni. So, taking this as background, the other problem which we face right now here with the drug arni is the renal functions, which we usually see that are impacted by RAS inhibitors. So, what is the impact of RAS inhibitor on renal functions? My question is to Dr. Ajay Belia.
Yeah, Dr. Amit, as you rightly and Dr. Abhishek also you rightly pointed out, that when we start ARNI or when we start RAS inhibition, there is some drop in blood pressure, and most of the physicians, we also initially we were afraid that this drug is causing so much hypertension. But if the patient is not symptomatic, we should try to continue this drug, because on long term these RAS inhibition or ARNI are beneficial for the patient. Similarly, we can think the similar things about the renal functions also. There's a steady decline in renal function if the patient is having diabetes, and there is extreme deterioration if the patient is having heart failure also. So basically, when we start RAS inhibition, or when we put the patients on these kind of drugs, so there is initially there is some extreme deterioration, which later on stabilizes, and this stabilization is seen better. The slope, as we can see in the smaller window, the slope of sacubitril with valsartan, it goes it nearly touches towards the better side, and basically it tries to remain parallel as the time progresses, or the age progresses of the patient. So on long term, basically initially we can expect a sudden drop in EGFR, but later on we can assume that this thing is not going to last forever. Next slide, please. And as we can see, the risk the relationship between annual slope decline, as we were talking in the previous slide, the baseline EGFR and risk of for adverse outcome is basically associated with, on long term, it is associated with lower risk for adverse outcomes. Next one. And the rate of EGFR decline, my connection, I think I'm getting a message. My connection is not stable. But am I audible?
Sir, you are
Yes,
audible.
Hello. Yeah.
yes, you are audible.
Okay. So as compared to enalapril in heart failure with reduced ejection fraction, the sacubitril valsartan group had a slower rate of EGFR decline. Next one. And if we compare the EGFR, there is definite improvement in EGFR. We see the clinical outcomes, the real world setting. Next one. So the dose recommendation, basically the target recommendation would be 100 milligrams twice daily, and the dose needs to be adjusted only in patient having severe renal dysfunction like EGFR less than 30 ml. And this subgroup of patients who receive sacubitril valsartan, it is shown to provide greater safety than ACE inhibitor in heart failure with reduced ejection fraction. Next slide.
As rightly said, that renal parameters are slightly deranged by starting this drug ARNI, but it is far safer than any ACE inhibitor or ARB. So we should try to maintain, the correct dose, the optimal medical therapy. We should monitor the renal functions every 2 to 4 weeks time, at least in the initial period, and we should continue with this drug. Does sacubitril and valsartan improve the quality of life in heart failure with reduced ejection fraction patients with type 2 diabetes mellitus? Because currently in India, as well as it was very much prevalent in outside India, that quality of life is actually very important, and now it is getting picked up in India also. What is the improvement in quality of life, and how we can see that a particular drug is working or not? So my question to Dr. Ajay Belia is that, is ARNI improving quality of life in heart failure with reduced ejection fraction patients with type 2 diabetes mellitus?
Yes, there was a question here. So the daily routine, the life, daily routine life works which a patient should be doing is put up in those type of patients, the patients who were having heart failure with reduced ejection fraction. So it was shown that sacubitril valsartan, the patient who were on sacubitril valsartan, they did definitely they did better than the patients who were on ACE inhibitor or ARBs. So almost up to the mark of 17% in quality of life indices improvement was seen within 8 months. Next one. So various parameters were put up on questionnaire, and this subgroup patients, they showed substantial improvement quality of life scoring over a year, and the improvement was up to 10.4 points by KCCQ scoring system. Next one. The routine, daily routine works like dressing, showering or taking a bath, walking for 100 yards on level ground, doing gardening, climbing a flight of stairs, jogging or hurrying, recreational or hobby activities. Previous one. So all these daily chores, the significant improvement was shown in 10 physical and social activities as early as 8 months. Next one. And this improvement was sustained for 36 months across all domains, all the 10 questionnaires which were put up, the 10 parameters which were put up, the improvement was sustained. Next one. So, if we can say that patients activity wise, they were 9 years younger, having the same uh, age group and the same kind of LV dysfunction. The patients who were on sacubitril valsartan, they were doing activities as they were 9 years younger than their counterparts. Next one.
So, since we are running out of time, so we'll just hurry up with this question. How can guideline-directed medical therapy in sorry be ensured in every ADHF patient at discharge? Will a heart failure checklist help in these kind of patients, because these patients are actually very vulnerable, and slight error in our management part or in our monitoring can give disastrous results. So how can my this question is to Dr. Abhishek Shukla. How can guideline directed medical therapy be assured in ADHF patients?
Okay. So thank you. As we already discussed what the guideline directed therapy and what should be done for the patients of heart failure. So to generalize those things, we used to have a protocol because everything cannot be remembered, everything cannot be. Sometimes we have so much busy schedules that we do not take time to just look after. So for that, we need to have a better protocol. We need to have a something that should be on checklist, something that should be checked every time whenever the patient comes to you. And this is important. Why? Because typical hospital course helps in rapid improvement in sign and symptoms, but still your patient is carrying a risk of mortality as well as risk of rehospitalization. Next. So if we have to address these things, there are expert consensus decision pathways and which have a key component of solution sets to inform the development of various tools that accelerate real-time use of clinical policy at a point of care. But these are basically very well applicable to the Western population where everything is, you can say, policy based, but here we have to look after for each and every clinical points, we have to look after for each and every therapy that should be there. Next. And after having applying all those guidelines which are meant for even the Asian population, we can have a very good result. And you can very well observe the trajectory here that shows that if the drugs were initiated early and when you should optimize the therapy, all those things should start whenever your patient first comes to your hospital. And later on, your first focus will be on clinical decompensation. You have a good discharge coordination with all your junior doctors that should know what to write on the discharge. And second, still your patient needs ongoing optimizing care that should be done with a follow-up OPD basis. And during this procedure or during this follow-up time, you should have to achieve all the goals which is recommended by the guidelines. Next, and by doing only this, you can change the trajectory. Now, this is a basically tabular representation of what to do, why we are not doing the same, and whether we are doing it optimally or not. So these three important things, what to do, that includes all the optimal drugs like SC inhibitors or ARBs or ARNIs or beta blockers, MRA, everbradine, whatever you are doing, whether you are doing optimally, yes or no, and if you are not doing, what is the reason? Because if you answer this question that I'm not doing, and you have an answer for that, why I'm not doing, that means you are addressing the questions of guideline directed therapy very well. But sometimes in our busy schedules, in our non-organized protocols, we usually miss, and we can sometimes may not add the subtle drugs like a ivabradine, like a MRA. So having a graphical representation, tabular representation, you need to ask questions every time. That helps you in achieving a GDMT. Next. So the therapy not only confined to the what the drug therapy you are focusing on, but you have to also focus on whether your patient is anemic or not. In this tabular chart, although the hemoglobin is not mentioned, but I personally feel that hemoglobin should be there, and you whether your patient needs the IV iron or not, whether his hemoglobin should be maintained or not, whether vaccination was there. Now this is not addressed in our country, and we have, although we have recommendations for COPD, CHF, chronically ill, diabetic, uncontrolled patients, but usually we in our busy schedule we do not bother regarding the vaccination, being the adult physicians or cardiologists. Medical device question is usually addressed by a cardiologist, and whenever you suspect, there are very subtle criteria which can anyone see in a patient of heart failure. If your patient is not well managed on any of the drug and you think that he is a case of lead bundle block, some CRT will help out. So you need to be properly referred to the center where they can analyze the importance, whether they can analyze, where they can analyze the use that might be beneficial for the patient. And you can also plan for the next visit. Do not drop your patient in between. Always make them more educated regarding what you are planning to do, where you are taking them, and what are the optimal treatment goal, and what are the optimal maximum doses where you want to take your patient. If your patient will understand all these things and you have a checklist, then not even you, your junior consultants can also manage the thing. Thank you.
Thank you, Dr. Abhishek and Dr. Ajay Belia.
Thank you.
And it was a nice panel discussion. Because we are already overshooting with time, we will take up the questions later after the heart failure session, and uh, Dr. Ajay Kumar Pandey has joined our session. So we will uh, welcome Dr. Ajay Pandey. He is head of department of cardiology at Galaxy Hospital, Varanasi. He has done his MBBS and MD from IMS BHU and DM from KGMC, Lucknow. Before joining Galaxy Hospital, Varanasi, he was working at Heritage Hospital, Varanasi, and he has more than 20 years of experience in field of cardiology. He is principal investigators of many MNC clinical trials, and he is faculty of many forums and conferences. So, welcome, Dr. Ajay Pandey.
Thank you, Dr. Amit, for your kind words. And I really want to congratulate you for this wonderful meeting which you have planned and invited me for my talk on this topic of heart failure with preserved ejection fraction. It was a wonderful session before me by Dr. Ajay Belia and Dr. Shukla regarding the heart failure with reduced ejection fraction, and there were a lot of very important topics were discussed. So I will share my screen.
So, you are sharing from your side?
Yeah, I'm sharing from my side.
Okay, sir. Thank you.
Can you see my screen?
Yes, sir. You are visible.
Okay. So the part which has been assigned to me, is the heart failure with preserved ejection fraction, the unmet need and the role of comorbidities. As Dr. Shukla and Dr. Belia were rightly, wonderfully discussed about the heart failure with reduced ejection fraction, uh, the hitch of the clinician, those who are treating heart failure with reduced ejection fraction, usually we are you know get stuck with the hypotension, and the patient, they didn't get an adequate medical therapy, the guideline directed medical therapy. Many times that we don't have a checklist to look into that. But mm, in the uh, heart failure with reduced ejection fraction patients, there are many patients, those who are really equally important in heart failure category. They are of preserved ejection fraction, and they are many times they are not well identified. So to looking into the etiology, the global burden, and other things, what I have brought it to all of you is the what the heart failure with preserved ejection fraction uh, is existing for. It is basically a progressive syndrome with preserved ejection fraction. And like as we in heart failure with reduced ejection fraction, we take ejection fraction less than 40%. The definitions have been changed for heart failure with preserved ejection fraction by different societies like American College and European societies, but they are all having a preserved ejection fraction, heart failure with EF more than 50%, and or heart failure with mid-range ejection fraction, that is 40 to 50%. It is basically a progressive evolution, and there are coexisting conditions, tissue alteration and neurohormonal alterations are there, which are operating upon in this pathophysiology of the heart failure with preserved ejection fraction, as we all know. And uh, classically, the heart failure with preserved ejection fraction by ESC guideline definition is basically where the symptoms and signs of heart failure are there, but LVEF is more than 50%. The patient should have a levels of natriuretic peptide assessment and at least one additional criteria, that is relevant structural heart disease of LVH or left atrial enlargement, or patient should have a diastolic dysfunction. If these any of these uh, are existing with preserved with symptom and signs and LVEF more than 50%, we can level them as an HFpEF. The heart failure with mid-range ejection fraction, the ejection fraction is varying between 40 to 49, with the established symptoms and signs of heart failure, as well as the levels of natriuretic peptides and at least one additional criteria of LVH or left atrial enlargement or diastolic dysfunction. So the characteristics of heart failure with preserved ejection fraction is basically the symptom and signs of heart failure. We are all aware about the typical symptoms of breathlessness, orthopnea, PND, exercise intolerance, fatigue, and swelling. I will particularly highlight on exercise intolerance because many times we miss this symptom in people of HFpEF or elderly people with hypertension, anemia, obesity of excessive intolerance, which may be sometimes a symptom of heart failure, and the typical signs of raised JVP, hepatojugular reflux, third heart sound, edema, and pulmonary crepitation. On these symptoms and signs, when we measure the left ventricular ejection fraction, and if the ejection fraction is more than 50% without an LV dilatation, they can be characterized as or as a HFpEF. LV diastolic dysfunction is the most important criteria or important component, I can say, in HFpEF, which can be assessed on these four uh, important or five important pillars. One is the structural changes like LV hypertrophy or left atrial dilatation. Doppler analysis in echocardiography like raised E by E prime ratios, abnormal mitral valve flow pattern, prolonged pulmonary venous A reversal. Biomarkers, which my other colleagues were talking about, like raised anti-BroBNP and BMP, which are equally important as it is important in heart failure with reduced ejection fraction. Many of our patients of heart failure with preserved ejection fraction, they do have an atrial fibrillation, which is a important comorbidities and which leads to deterioration in their heart failure functions. Invasive hemodynamic monitoring, we can use it that increased LV and diastolic pressures and prolonged tau and increased LV stiffness. They are the important factors for HFpEF. If you look into the trends in prevalence of heart failure with preserved ejection fraction from 2005 to 2010, the blue part of this bar diagram, which shows around 30 to 35 or 40% of the whole population, which was studied in the different guidelines. They have of hospitalized patients of HFpEF. They are more or less in different, starting from 2005. It is more or less, in an increasing trend, or at least, half of the population, and around 30 to 40, 50% of population is with heart failure with reduced ejection fraction. So the medical scenario in India for HFpEF is that around 25% of patients in Trivandrum Heart Failure Registry, which is one of the most important registry done in our country, were of HFpEF patients, and the 33% of these patients were women, and they're higher than the men population. The participants in HFpEF are more likely to have a history of atrial fibrillation or flutter compared to patients of HFrEF, which is around 12%, and in hospital mortality was higher for participants with HFrEF, 9.7% compared to HFpEF, which is 4.8%. So it is very true that patients of HFpEF was not that sick, but their morbidities are many, and they are really symptomatic many times. So if you see the unadjusted 3-year all-cause mortality rate was significantly lower for participants with HFpEF, that is around 40% compared to HFrEF, which is 46%. So they are really significant. So to summarize the burden of HFpEF in India, HFpEF is now the dominant form of heart failure in aging population globally. As we all know that our population in India as well is aging, and many of us as a clinicians are seeing more and more patients of 65 years plus, 70s, and few of them are in 80s. Compared to HFrEF, these patients are more older, the HFpEF patients, and they're more likely to be women, and the prevalence and incidence over the last decade has increased for HFpEF, and the comorbidities have also increased over time. So, what is the pathophysiology of HFpEF? If you compare the HFrEF or heart failure with reduced ejection fraction compared to HFpEF, the comorbidities in HFpEF, which are many, I will enumerate in the further slides, they leads to endothelial cells alteration like microvascular inflammation, endothelial activation, and ultimately decreased nitric oxide and endothelial mesenchymal transition. And this cardiomyocytes, they've got alterations in the microvascular ischemia, and concentric LV remodeling occurs. Whereas in HFrEF, the endothelial cells further they get impaired, and cardiomyocytes, direct myocardial injury occurs. There's a cell necrosis and apoptosis. Eccentric LV remodeling is seen, which is responsible for neuroendocrine activation, and all our HFrEF guideline directed medical therapies are basically dependent upon RAS blockage and blockage of sympathetic nervous system as well. So in the pathogenesis of HFpEF, there are multiple diastolic and non-diastolic abnormalities in cardiovascular functions contribute to the HFpEF pathophysiology. Starting from hemodynamic mechanism, if you look into, there are left heart congestions, diastolic dysfunction, and left atrial hypertension, which is very commonly depicted in our echocardiographic findings. Pulmonary vascular disease and right ventricular dysfunction, volume overload, microvascular inflammation, and the cellular and macromolecular mechanisms like cellular and extracellular structural changes and cardiometabolic abnormalities are seen. Now coming to the diagnostic part, that how can we diagnose that the patient is having a HFpEF, and what are the diagnostic criteria? And if you look into this patient's profile, we very commonly see such type of patient in our day-to-day clinical practice. She's a 74-year-old woman present at an outpatient clinic with increasing fatigue and breathlessness. And Newark Heart Association classification class 2 to 3 symptoms were there. She had a history of long-standing hypertension, diabetes, and chronic kidney disease. Her physical examination revealed the BMI of 32, means she was, obese. Blood pressure of 120 by 65, that's controlled. Pulse rate is 80. The neck veins are not visualized, but the basal lung crackles are there, and mild pedal edema is there. On the biochemical evaluation, her anti-pro-BNP was high, 550 picogram per ml, and EGFR is 48 ml. Her echo revealed LVEF of 60% with LVH in echocardiogram, and the E by E prime ratio is 10, and left atrial volume index is 33 ml per meter square. So the question arises, with these things in our hand, what would level her as a HFpEF or not? So looking into the diagnosis of HFpEF, we should start with symptoms and signs. Basically, symptoms and signs for HFpEF, they mimic more or less the symptoms and signs of HFrEF. That is the third heart sound, the gallop rhythm is there, there's a pulmonary congestion, pedal edema, and hepatomegaly. There are clinical characteristics of different trials and different publications. They have seen the HFpEF and HFrEF comparison in their symptomatologies and clinical characteristics, starting from Mayo Clinic's retrospective trial to different registries like Optimize HF registry, Adhere registry, and what they have seen over the different registries and retrospective trials, that patients of HFpEF, uh, the they are nearly equal in number. Around 50% of most of these trials and registries, they say that HFpEF and HFrEF are they are nearly equal in their numbers. Age, definitely the HFpEF people are they are more aged or elderly population. Female preponderance is there. The BMI is more compared to HFrEF. They are more hypertensive. The coronary heart disease is more commonly seen with HFrEF patient, but the atrial fibrillation is more common with HFpEF. Diabetes is nearly equal in both of them. Creatinine has got a similar type of performance, and the clinical signs are nearly more or less similar. So basically, if you look into the mean age, uh, it is more in than HFrEF patients. In patients of HFpEF, the majority are women, and the hypertension is more compared to HFrEF. The CAD is less, and it is basically CAD is more common in HFrEF, but the atrial fibrillation is high compared to HFrEF. Diabetes is around similar in both the groups, and BMI is higher in HFpEF group. So many elderly hypertensive ladies are tired, breathless, or having ankle edema, but they don't have heart failure. Is it true? The problem is not the same, because there are different regional variations also which have been observed in different studies. And there's a TopCat trial which has been published in Circulation 2015, where they have taken from different population like US, Canada, Argentina, and Brazil population. The HFpEF were different compared to placebo, but in Russia and Georgia, there, you know, uh, the variation is different compared to the Western population of US. So diagnosis of heart failure, what do the guidelines say? The guidelines, the recent ones from ESC and HACC, what they say, that recognize the complexity of the diagnosis of HFpEF due to non-specific symptoms. Many times the patient, they have a non-specific symptom. So being a clinician, we many times miss such patients, and many of these patients, those who are presenting with shortness of breath, are misdiagnosed as respiratory symptom. They were treated with inhalers and, you know, bronchodilators, but they don't respond to them. The recommended that diagnosis of HFpEF is based on the findings of symptoms typical of heart failure, signs of heart failure, and normal or only mildly reduced LVEF. When we look into the LVEF, because most of our clinicians, their eyes are set for looking only LVEF in a echo reports, so they don't look into the diastolic abnormalities, and the diastolic abnormalities are basically giving us a clue that these patients are basically having a HFpEF. The ESC guidelines Also specify for the diagnosis of HFpEF that objective evidence of other cardiac function and structural alterations underlying heart failure are there, and elevated levels of natriuretic peptides like BNP, which is more than 35, and anti-BNP more than 125. Stress test or non-invasively measured elevated LV feeding pressures may be needed to confirm the diagnosis. But ACC AHA guidelines says that evidence of abnormal LV diastolic dysfunction can be determined by Doppler echo or cardiac catheterization. Doppler echo is one of the important tool in our hand, and it's very easy for all of us to diagnose these patients bedside or even in our routine clinical practice without any invasive efforts. So diagnosis of HFpEF is more challenging than the diagnosis of HFrEF because it is largely one of the excluding then potential non-cardiac causes of symptoms suggestive of heart failure. So we have to behave a little more intelligently in such patients. The important aspect of heart failure guidelines is that in 2016 ESC guidelines, what they have said that heart failure with mid-range ejection fraction where the EF is around 40 to 49, and heart failure with preserved ejection fraction where the EF is more than 50%, the elevated levels of natriuretic peptide plus the relevant structural heart disease or diastolic dysfunctions are important parameters which needs to be assessed. TopCat trial, which I have discussed with you previously, also highlights the natriuretic peptide criteria for diagnosis of HFpEF, and what they have seen that when they were enrolling on the basis of hospitalization in past year for which the management of heart failure was a major component, and they have also taken a criteria of natriuretic peptides and in their inclusion when they were comparing and including the patients for HFpEF. Regarding obesity and HFpEF phenotype, we see that there are non-obese type of people, those who are having HFpEF, as well as obese people, and the the obese people, they usually have a very high pulmonary capillary wedge pressure. There's a maroon diagram is shown here. This is where the obese patient compared to non-obese patient with the blue diagram. So the non-obese patient on the same anti-proBNP level, the pulmonary capillary wedge pressures are more higher for obese people compared to non-obese. Now, the particular case which I was discussing, 74-year-old women with increasing fatigue and breathlessness. There is a history of long-standing hypertension, and the clinical signs were there of heart failure. The anti-proBNP was high, and the LVEF was normal with LVH. So diagnosis of heart failure, we need understanding the toolbox. And what are the toolbox with us? One of the most important is transthoracic echocardiography. It is a method of choice for assessment of diastolic function in both left and right ventricle. So I basically like to, definitely uh, stress on this aspect for our clinicians and our physician colleagues that always look for diastolic function abnormalities whenever we are looking for a complete echo evaluation and a comprehensive echocardiographic examination incorporating all relevant 2D and Doppler data is recommended. And what are the important parameters which needs to be assessed is the measurement of LV basal, annular longitudinal myocardial shortening, uh, or lengthening velocities, and measurements of LV systolic or diastolic functions, which includes the peak systolic shortening velocity and early diastolic E prime lengthening velocity. So E by E prime ratios and longitudinal strain rate, these are important parameters. Like in the patient of mine, which we are discussing about, uh, the patient's LV hypertrophy is there and LV mass index is more than 95 gram per meter square. Whenever we are looking for an echocardiogram, it is very important that we see very quite often the reports of echo which show that patient has got a LV hypertrophy, mild or moderate concentric LVH. But it is very important and mandatory to measure and to reveal about what is the LV mass index, and for this we need to have a patient body surface area as well. So patient's weight with the body surface area assessment is an important clue to give us whether the patient is having LVH or not. Any women having more than 95 and men more than 110 of LV mass index is having LV hypertrophy. LA remodeling means left atrial volume index should be more than 34 ml per meter square that our software in echo calculates very well. And elevated LV filling pressure, for this we need to measure E by E prime ratio. Many of our colleagues, those who are working on echo, they didn't mention the diastolic E prime ratios, because until unless you assess the Doppler velocity, the tissue Doppler, it is very difficult to look for E prime, and E by mitral flow and E prime by tissue Doppler. If it is more than 14, that gives a hint of elevated LV fluid pressure. So whenever we are looking for an echocardiographic examination, these are the important things which has to be noted down and should be mentioned for a proper HFpEF diagnosis. Until unless we do that, it is very difficult for us to diagnose it. Now comes the role of stress echo, because many of our patients, they are asymptomatic at rest and become symptomatic on walking or climbing up hills. So allow the stress echo allows us the detection of a diastolic dysfunction related to exercise exposure. A diastolic stress test can be performed with an echocardiographically, typically using a semi-supine bicycle ergometer, which is a common exercise protocol which many is used in most of the stress labs. And the parameters which are assessed is LV, E by E prime ratio, and pulmonary artery pressure, systolic dysfunction of the longitudinal strain, stroke volume, and cardiac output. So in this lady, the echocardiographic at rest was showing a normal LV filling pressure, and the E prime P prime was less than 14, and the TR velocity jet is less than 2.8 meters per second. But after doing an exercise, which usually gives her the symptoms, the E by E prime ratio increased to more than 14 and TR velocity more than 2.8. This was the TR velocity, which is very commonly you see across the tricuspid wall flow. And that reveals that patient is having diastolic dysfunction, which get aggravated on exercise. Though cardiac magnetic resonance imaging is one of the uh, very important diagnostic tool and a gold standard for the measurement of volumes and mass and EF of the both the left and right ventricles. The preferred imaging method to assess the myocardial fibrosis, and the different parameters like tau, which looks for constant of pressure decay, beta, the passive stiffness, and ECV, the extracellular volume, can be calculated using the T1 relaxation time. And in basic hemodynamic monitoring, there we have to look for the evidence of abnormal LV relaxation, filling, and diastolic distensibility, and the parameters like pulmonary capillary wedge pressure and LV end diastolic pressure. And these are the cardiac catheterizations data, which show that in baseline and with exercise, the pulmonary capillary wedge and LV EDPs they get raised. So if I will put all together, though it was quite dry and boring, the new HFpEF diagnostic criteria are there, and those who are definitely in a real heart failure clinical practice, they need to under note all these diagnostic scores. There are HFpEF diagnostic scores are there, and they can be noted on a play card and can be very well measured at the in OPD clinic. The Mayo clinics have given the consecutive by unexplained dyspnea patients, but by looking into these multivariable models like AF, body mass index, age, E by E prime ratio, pulmonary artery pressure, and all, and they have reduced a diagnostic score of H2FPEF, that is H2 is for heavy and hypertensive, uh, mm, F for atrial fibrillation, P for pulmonary hypertension, E for elderly, and F for filling pressure. And higher the score, the H2 HFpEF score is from 0 to 9, and higher the score, higher is the probability of HFpEF in that patient. So looking into our patient, the HFpEF score is around 5, and which is a probability of 0.8, which is quite significant. The other ESC scores are also there. I'm not going into the detail of those scores because they make the things more dry and more unrealistic for all of us. But there are PEF2 scores are there by divided by, and the ESC has given some major and minor criteria depending upon the functional, morphological, biomarkers in sinus rhythm and biomarker in atrial fibrillation. And if there's a major criteria, 2 points are given, minor criteria, 1 point is given, and if more than 5 points, there's a definite HFpEF. So like rheumatic heart disease criteria, the ESC has given HFpEF criteria. and it is very important to have these criteria in your clinics, and you can very well ascertain them. And these criteria basically requires functional, morphological, biomarkers, and inclusion for the diagnosis. So in our case, the NT-proBNP, the biomarker is more than is around 550, and with LVH in the echo with E by E prime is not that high, but it is 10, and LA volume index is just on the borderline 33 ml per meter square. So the ESC HFpEF score is around 4, and requires further workup. Now coming to what are the real comorbidities for development of this HFpEF, and here it is the most important part for all our clinicians to understand these comorbidities, for management of these comorbidities, because in there's still most of the guidelines they did not have any foolproof or class 1 clinical indications of any medical therapy except the diuretic, which is responsible for relief of the congestive symptoms. A lot of drugs are under trial, like ARNI, ARBs. They're under trial, and different trials have been done. With few of them are having some of the important outcomes, but we have to understand the comorbidities like cardiac causes of hypertrophic cardiomyopathy, systemic hypertension, and CAD. These comorbidities needs to be corrected. Extra cardiac causes like overweight, obesity, which is very less importance is paid on these, and from our patients as well as from the clinician as well. Metabolic syndrome. My other colleagues, Dr. Ashutosh and Dr. Pallavi, are going to talk about the diabetes, but we all know that diabetes is a very important aspect and a very important comorbidities for HFpEF. People those who have got long-standing diabetes, they develop all those, endothelial dysfunctions and muscle fibrosis and all those things in myocardium, which leads to HFpEF as well. Patient with insulin resistance, kidney disorder, and CKD patients, COPD and sleep apnea, muscular deconditioning, and iron deficiency. Regarding iron, Dr. Shukla was talking about many of our heart failure with reduced ejection fractions are anemic, and we don't able to make the quality of life better because we are not paying attention to their correction of anemia. Same is the case with HFpEF as well, that we need to correct patient with the iron deficiency as well. And there are social and demographic factors which many of them we cannot correct it, like aging we cannot correct, female gender, menopause, and sedentary lifestyle. So all these comorbidities lead to the cellular and biological changes in heart, which is cardiac hypertrophy or fibrosis and skeletal muscle dysfunction and neurohormonal dysregulation, and all those sort of microvascular and mitochondrial dysfunction, endoplasmic reticular dysfunction, disrupted cyclic GMP and PKG signaling mechanism, which leads to HFpEF, decreased cardiac efficiency and decreased ATP production and myocardial perfusion and cardiac relaxation. So all these complex pathophysiological mechanisms are operating upon. So we have to take care of those comorbidities at least, so that will help in our patient management. Hypertension and age are the most important major risk factor for HFpEF, but CAD, hypertension, pulmonary hypertension, aging, and obesity plays an important role. So there's a complex interplay of all these factors like atrial fibrillation, anemia, COPD, frailty, diabetes, OSA, CKD. They all play an important role. Now coming the burden of comorbid heart failure with reserved infection and diabetes mellitus. How does the effect of diabetes on HFpEF? These are the important parts during diabetes, which are increased like BMI, systolic blood pressure, fibrosis, congestion, endothelial dysfunction, LV filling pressures, rates of ischemic heart disease and cardiovascular death, and functional status, quality of life, exercise capacity, they all reduce. These all problems in diabetic population leads to alteration in sodium handling, increased volume overload, and release of pro-inflammatory cytokines, poor skeletal muscle function, and impaired peripheral oxygen delivery, which are responsible or can be targeted by different mechanism. Like many of my colleagues will be speaking upon the sodium glucose co-transport SGLT inhibitors, which are basically working on these pathways. Many of the anti-hyperglycemic drugs those who are working on the pro-inflammatory cytokines and decreasing the adiposity through the caloric restriction and an exercise training program. These are the important, modalities for management of HFpEF in diabetic population. So regarding diabetes and HFpEF, about 45% of patients with HFpEF have diabetes, and their association of diabetes with all-cause and cardiovascular mortality and heart failure readmission was stronger in HFpEF than in HFrEF patients. Diabetes in HFpEF patients with greater burden of comorbidities, increased adiposity seen with diabetes mellitus leads to release of pro-inflammatory cytokines. There is other mechanism leading to systemic inflammation in HFpEF patients with diabetes. Poor functional status among diabetes patients with HFpEF is likely secondary to poor skeletal muscle functions. Functional capacity, as we all know, has been shown to increase in HFpEF following an exercise program. So exercise rehabilitation program is one of the important factor or important treatment modality in patients with HFpEF, as it is also important in HFpEF patients. There's a higher burden of comorbidities in patients with diabetes and HFpEF. Reflects the need of a team-based approach. And as Dr. Amit has already gathered the team of diabetologists, endocrinologists, critical care physicians, cardiologists, and he himself is a cardiac surgical specialist. And so we all require and primary care physicians, many of us those who are attending this program and being a faculty member. So all these team-based approach is required in treating such patients. It's not a job of a single person like a cardiologist or a endocrinologist to take care of these patients, and we require team effort. What is the scenario of India regarding the etiologies and comorbidities of HFpEF and HFrEF? Definitely, rheumatic heart disease is one of the important part in HFpEF because many of the valvular heart disease patients, when they didn't have reduced ejection fraction, but still they have stiffness of the myocardium and the HFpEF is there. The ischemic heart disease is nearly the same in both the groups. Hypertension is more common with HFpEF, and the history of comorbidities like diabetes is nearly equal in both HFpEF and HFrEF, but history of atrial fibrillation is more nearly double in HFpEF compared to HFrEF. Stroke, COPD and CKD are more or less similar in both the groups. So there is one other important part which I want to highlight, that HFpEF has got different 4 phenotypes as well. Like one is aging phenotype, where the community-based studies have shown that the age-related systemic changes occurs in myocardium. Obesity phenotype, as I have discussed with you, that the people with a high BMI, they are prone for having HFpEF, and this is the obesity phenotype. There's a pulmonary hypertension phenotype where the prevalence of PH is slightly greater in HFpEF than in HFrEF, and CAD phenotype where we see that prevalence of CAD ranges from 35 to 53%. So there are 4 types of phenotypes, and HFpEF compared to HFrEF, if you see, basic pathophysiology is reduction in the systolic function, LV systolic function in HFpEF, whereas there is an alteration in LV filling in HFpEF is there. Female preponderance is there in HFpEF, and aged population with more history of hypertension, AF, and valvular heart disease are seen. Changes in LV, there's LV dilatation and eccentric remodeling, but in HFpEF there is a concentric remodeling, and the concentric LVH is there. Myocardial changes, there is a myocardial stress injury is more pronounced in HFrEF, but there is a myocardial inflammation and fibrosis is more pronounced in HFpEF. And the impact of vasodilators. Vasodilators are definitely like ARNI and ACRB and RAS blockage. They improve the LV systolic performance, but they have got still little impact on LV systolic performance, and there are still a lot of trials and researches are going on in this era. So if you look into the patterns of ventricular, involvement in HFrEF and HFpEF, the HFrEF there's a volume overload. In HFpEF there's a pressure overload. In HFrEF there's an increased diastolic pressure. Here is an increased systolic pressure. In HFrEF there's a diastolic wall stress. In HFpEF there's a systolic wall stress. There's a series addition of new sarcomeres in HFrEF. There's a parallel addition of new myofibrils in HFpEF. Chamber enlargement is seen in HFrEF, but there's a wall thickening in the HFpEF. The eccentric hypertrophy is there in HFrEF, but there's a concentric hypertrophy in HFrEF. So this slide gives you a clear picture of left ventricle, what happens with HFpEF and what happens with HFrEF. Basically in heart failure with reduced ejection fraction, there's a volume overload on the left ventricle. There is in HFpEF, there's a pressure overload on the left ventricle, and we need to tackle those as per their requirement. The different features of HFrEF and HFpEF: diabetes, hypertension, obesity, and aging with a preserved ejection fraction of heart failure with more than 50% or above. This is the HFpEF. This is the pathophysiology which I have already discussed. The therapeutic options to HFpEF are being explored, and those who have got volume overloaded, they are treated with diuretics. But the other drugs like comorbidities has to be tackled, and the comorbidities need to be most important. The myocardial ischemia, CAD, and different pathophysiological factor with reduced ejection fraction of EF less than 40%. This entities have PrEF where the patients need to be tackled for the therapeutic options of guideline-directed medical therapy of ACE/ARB, MRSAs, beta blockers, ivabradine, ARNIs, and digoxin, and implantable defibrillators and cardiac beat syncotin therapy. So all these are basically, if you treat them, HFpEF and HFrEF, there's a reverse remodeling, and which can be, the patients can improve as well. So regarding outcomes, no improvement in outcomes in seen with HFpEF with major public health problems in over the years, because with reduced ejection fraction, we have all seen that from 1987 to 2001, the mortality has decreased in HFrEF, but the survival more or less, there's no improvement in the survival in HFpEF in similar years. The mortality reverse in HFpEF and in HFrEF, but the HFpEF is same around 75%. But the HFrEF has got a higher mortality of 100 of compared to HFpEF. The age ischemia, etiology, higher NYHA class, lower systolic BP, and higher antiprotoporphyria, the independent predictor for all-cause mortality in HFpEF group of patients. The more non-cardiovascular deaths are seen with uh, patients with non-cardiovascular deaths. Majority of deaths in heart failure with preserved ejection fraction are having cardiovascular causes. This is seen in this diagram. So the clinical outcomes of HFpEF, hospitalization and evidence based on an observational study is that heart failure with CV readmission in patients with HFpEF is around 10%. Readmitted within 30 days of hospital discharge, whereas 37% readmitted with 1 year of hospital discharge. If you compare HFrEF and HFpEF, the all-cause admissions are not that high, but in patients with HFrEF, the hospitalization is comparatively more compared to HFpEF. The HFpEF hospitalizations are pretty high, and there's 5-year outcomes analysis of patients with in the registry. A lower rate of heart failure readmission was observed in HFpEF and HFrEF. So to summarize the whole talk, which really was very extensive for all of us, there are 4 important points. One is more than 1/3 of patients of heart failure, that is LVEF, more than 50%, with the prevalence continuing to increase over time. So this is the time to observe and realize that heart failure with preserved ejection fraction is not an unknown entity, and it should be clinically identified. We need to treat them properly. We need to identify them and diagnose them properly. LV diastolic dysfunction or increased LV filling pressure from LV stiffness and abnormal relaxation is a fundamental mechanism of HFpEF, which was previously known as diastolic heart failure or diastolic dysfunction. So what we previously used to call as a diastolic heart failure is now basically a HFpEF. An association of diabetes with all-cause and cardiovascular mortality in heart failure, readmission burden of comorbidity, worse functional status, and elevated markers of inflammation, with more signs of volume overload was stronger in HFpEF than in HFrEF patients. And overall cardiovascular mortality in HFpEF is lower than HFrEF because these patients, they don't have that high mortality as HFpEF. However, the majority of deaths in HFpEF are due to cardiovascular causes, like patients those who are having HFpEF with atrial fibrillation, hypertension, they have many times stroke or some other cardiovascular cause. There is a high rate of heart failure hospitalization in HFpEF and HFpEF. However, a higher rate of non-heart failure readmission is observed among patients with HFpEF because many of our patients of HFpEF they get admitted to the hospital because of non-cardiac or non-heart failure related causes as well. So that is what we need to understand, and we have to work upon that. And I'm really thankful and for your, everyone's who have participated and given their, uh, precious time for this uh, mm, meeting and seminar. So now it is over for discussion and questions and comments.
So thank you, sir. It was a very good presentation, a very brief introduction to heart failure with preserved ejection fraction and what we need to do actually. Sir, there are few questions. I'll start with you, sir, and then after that, I will ask questions from Dr. Abhishek and Dr. Ajay also, Dr. Ajay Belia.
Yes.
Sir, can first question to you is that can RV dysfunction also cause heart failure with preserved ejection fraction?
There are a few group of patients. Basically, what we are what we are discussing about is really left ventricular ejection fraction. But people, those who are having left ventricular ejection fraction, ultimately, their LV filling pressure starts rising up. They develop pulmonary hypertension, and RV also start, having dysfunction. Isolated RV dysfunction are not are filled up into the criteria of HFpEF, but many a time we see that patients those who are having isolated RV abnormalities, those are separately dealt with. There are not in different guidelines like ESC guidelines or your American College guidelines. They are basically discussed regarding left ventricular functions or left ventricular. Isolated RV dysfunction is a separate entity, but as we all know that RV starts also dysfunctioning over the time when there is a LV dysfunction is there and the filling pressures are increasing because the patient starts developing sign and symptoms of right heart failure as well. Patients start having raised JVP, liver congestion, all those things. But basically, the when we are discussing about the definition part, it starts with left ventricular ejection fraction, and the parameters are diagnostic parameters are basically taken from left ventricular parameters. Those who are mitral flow abnormalities, LV diastolic abnormalities, LA pressure abnormalities. So these are the guidelines which have been established.
Sir, my next question is to Dr. Abhishek. Which is the first heart failure drug which you'll prefer to start in ADHF patients and why? Dr. Abhishek is here. Sir, you can also answer this
Yes,
question. Sir, you please.
definitely patient with acute decompensated heart failure, the decompensated heart failure patient, they usually require a diuretic therapy as a, though if the patient for heart failure patient, the first drug which needs to be started is ASARB, but that is the most important drug which has to be started first on the armamentarium. But usually acute decompensated patient, they usually are volume overloaded and they present with acute decompensation, hypoxemia. Those patients they require a diuretic therapy. So definitely giving a initial diuretic therapy is one of the important mode of treatment in acute decompensated heart failure. Though many of times the patients get improved with diuretic therapy, and there are the other causes which are there for acute decompensation, like somebody who has developed acute ischemia, which is responsible for acute decompensation. We have to look for the what is the real cause of precipitation of acute decompensation. Somebody who has developed an acute viral respiratory infection, or somebody who has developed an acute atrial fibrillation with fast ventricular rate. So there we need to tackle the heart rate. There we need to tackle the chest infection. for management of those acute decompensation etiologies. Sometimes we need to add on inotropic agents like dobutamine and all those things as a supportive therapy for patients, milrinone and dobutamine for patients who have acute decompensation. Once the patient is off these inotropic support, definitely if the patient is the other parameters are okay and is already initially treated with ACE-ARB and then on ACE-ARB tolerated, is an option to go for ARNI in such group of patients. That is what
So my
my
next question is to Dr. Ajay, sir, Dr. Ajay Belia. Since both are Dr. Ajay, so Dr. Ajay Belia, we were talking about two drugs, the ARNI and the SGLT2 inhibitor for management of heart failure with reduced ejection fraction and diabetes mellitus. Which should be the drug of choice for a management of heart failure with reduced ejection fraction? Because both are having equal benefits.
Definitely, if the patient and the time permits, definitely both should be started in a patient having diabetes with acute decompensation. So, ARNI is definitely the number one choice because it is helping in diabetic part also. Plus, we have other treatment options to control hyperglycemia if it is there. So, in my opinion, I think ARNI is number one, and if the patient and the scenario permits, we can definitely add SGLT2 inhibitors also.
I just want
Okay,
to add
okay.
one more point, Dr. Belia, that if the patient is acutely decompensated and volume depleted, definitely sometimes starting an SGLT inhibitors may not be a good option. So as you have rightly mentioned that definitely we
Yes,
should start SGLT inhibitor and looking into the volume status of the patient. If the patient is dehydrated or the patient is volume depleted, we
that
should
was
not
what I
add on
meant.
it.
You have to see the volume status also.
Right.
Sir, Dr. Ajay Sir Varanasi. Sir, I'd like to ask you two questions, sir. First is that we were talking about pulmonary capillary wedge pressure and NT-proBNP in heart failure with preserved ejection fraction. There was a slight mention of that.
Yeah.
And if there is a role of pulmonary capillary wedge pressure, then
Yeah.
there should be a role of albumin levels in the blood. So, what is your take on this? This is a question from the audience.
Definitely, that patients, those who are uh, hypoalbinemic, because these parameters they get changed on different like patients those are anemic, those who are having hypoalbinemic. There, these factors also impairs your LV filling pressure. So what we are talking about is a raised pulmonary capillary wedge pressure in a normal or a stable hemoglobin or a normal albumin level. If the patient has got a hypoalbuminemia or anemia, definitely patient will have an abnormal filling pressure. So if the patient, the other parameters like hemoglobin, albumin, they are stable, and then we are measuring for capillary wedge pressure. And nowadays, nobody measures this capillary wedge pressure or does the invasive hemodynamic monitoring in the era of simple availability of non-invasive facility, because you can get an idea of pulmonary capillary wedge pressure by looking into E by E prime ratio and LA volume index. It is a very simple bedside calculated test. So it's basically a theoretical exercise for people those who are doing a theoretical or a research trial like a work for measuring direct cardiac cath assessment. Otherwise, it's not that important tool nowadays to use in a day-to-day clinical practice.
The one last question to Dr. Ajay Belia sir, Faridabad. So, MRA has shown mortality benefits in heart failure with reduced ejection fraction patients. How frequently you are using MRA with ARNI, especially in relation to hyperkalemia, which both of them cause?
Hyperkalemia. We have to be very careful and we have to be very observant. We have to monitor the potassium levels, and definitely we'll have to withhold MRA if the patient goes into hyperkalemia, especially in a scenario with renal failure patients.
Okay. There is a question
Hello.
from Dr. Arvind. You can
Yeah.
directly unmute yourself and ask the question, Dr. Arvind.
Definitely, when we are treating such patients and they are on guideline-directed medical therapy, it is very, very important for patient to measure their electrolyte levels, particularly potassium levels, because when the patients are in ASARB or ARNI and they are on, MRA like glucose drug, it is very important to measure potassium if the patient cannot measure potassium, it is not a wise idea to put them on these drugs. What was the question of Dr. Arvind?
Sir, hi sir, very good evening.
Good
Sir,
evening.
I just want to ask one question that sometimes we encounter patients of valvular heart disease post-operatively who have a long-standing atrial fibrillation. Sometimes it is controlled uh, within a, sometimes it is controlled, but I've seen some patients who turn up after 1 year or so with lower ejection fractions. So that so how to manage these patients? Can we put them directly on ARNI in these cases? Because long-standing AF can cause LV dysfunction in
Yeah, sure.
overdue course.
Definitely, there are two group of patients who develop atrial fibrillation. One is the mitral valvular disease. If the patient is having a mitral stenosis, then definitely,
Yes.
LV is not that volume overloaded, and the cause of atrial fibrillation is because of LA enlargement. There, the benefit of ARNI may not be that great, but definitely the patient, those who are having mitral regurgitation, long-standing mitral regurgitation, as I've already discussed with you in my slide, the patient with valvular heart disease, they usually have a HFpEF. Technique of our patient with mitral regurgitation, if you measure their ejection fraction, it is more than 55-60%. But that 55-60% also is a low ejection fraction in a regurgitant, significantly regurgitant mitral valve, because the ejection fraction should be more than 70-75%. So basically, they are having a reduced ejection fraction compared to their high volume of mitral regurgitation. Those patients, if they develop atrial fibrillation because they are already having a volume overload of LV, volume overload of LA for long-standing time, that maybe are using an ARNI in that group of patient is a good option. But most of the time, what we have seen in the cardiac, post-cardiac surgery, atrial fibrillation is a common entity, not only in valvular heart disease, but even in ischemic heart disease as well. And that you can answer me better, you can answer better than me, that what is the etiology, because many of my surgical colleagues, they told me that because there are some amount of edema and all those things are there when you open the pericardium, they are more responsible for having atrial fibrillation post myocardial surgery and all those things, and they usually put them on amiodarone for prevention of those atrial fibrillation. But definitely, ARNI is a good drug of choice for volume overloaded HFpEF or HFrEF type of patient, not for mitral valve disease stenotic patient, those who are having atrial fibrillation, because their etiology is something different. The LV is not that volume overloaded.
I'd like to add 2 points here. Surgical point of view, there is one entity called the preservation of the chordae tendineae. So if during surgery these things are not preserved, so they cause acute LV dysfunction.
Right.
That's fine. I'm not talking
Pardon?
about those patients.
Am I audible?
Sometimes,
Yeah.
yes, sir, you are audible. So actually, my question was different because sometimes I'm not, even if we preserve, I've seen two patients in immediate post-op period as well as in the late post-op period as well as in follow-up. One of the patient we had done MVR for stenotic for MS, not for MR. So LV function was preserved post-operatively as well. But the AF was yes controlled with control ventricular rate, but over a period of time, say I followed up the patient came up in my OPD as a follow up after 1 year with a complaint of breathlessness. Valve function is okay, but with LV function of 35. Yes, AF was there with the control rate. So in that case, I could not find any known cause for it. So I've gone through the literature, and that's why that might cause a long-standing AF in those patients. Even if you take care all those precautions to post-caudal preservation, myocardial protection during surgeries and all.
The
I'm talking about
etiology,
those
the
patients can be
etiology there, Dr.
when we
Arvind,
put
can be
those patients.
tachycardiomyopathy because the patient, those who are in AF, AF
Yeah.
begets AF and tachycardiomyopathy
Yes, sir.
gets sustained. So it is better to
Yes,
for
sir.
these patients to either cardiovert them and put them on amiodarone to keep them in normal sinus rhythm. You people do quite
Right.
amount of some surgeries of mace surgery and doing all those things during the time if it is possible. If it is possible to keep them in sinus rhythm, because if the patient is in AF for a long time, definitely and they develop tachycardiomyopathy, that may be the reason for deterioration in LV function.
Okay, sir. Thank you, sir.
Thank you, sir. Thank you to all our panelists, Dr. Ajay Pandey, sir, Dr. Ajay Belia, sir, Dr. Abhishek Pandey. Dr. Sanjay Kumar is also here, and he is HOD, Head of Department of CTVS IMS BHU. He is professor and currently working as HOD. He did his MBBS from JIPMER Pondicherry and post-graduation MS and MCH from from CMC Vellore. Uh, did fellowship FRCS from all three Royal College of Surgeons, Edinburgh, England, and Ireland. He worked in England, London, Oxford, and Birmingham in UK, and Yale's University in USA. Has special interest in mechanical circulatory assistance and heart transplant. He has more than 135 articles published internationally, and he is having fellowship and membership FRCS CD, FRCS England, FRCSI, and FICS. And now I will hand over the session to Dr. Sanjay, sir, for online inauguration of this program. And after that, he'll say a few words on World Diabetes Day. And after that, we'll continue with our next lectures. Over to Dr. Sanjay, sir.
Sir, you are on mute, sir.
Sorry. Thank you so much, Amit. I really find it a privileged situation to be amongst those real renowned diabetologists and cardiologists group of physicians here, and I really thank the industry for giving me the opportunity to moderate this inaugural session of this. I would like to say that in this panel of a speaker, we have renowned cardiologist and also our esteemed teachers and seniors from BHU, like Professor S.K. Singh, Professor Madhukar Rai. These are people who need no introduction. They are the doyen in their areas, and we'll be listening to them in the subsequent series of lectures. So far as the previous speakers have already addressed this problem, I would just like to say thing about this. This diabetes is a real issue, and as a surgeon and being a cardiothoracic surgeon, we find this problem majority of our patients when we operate them. And I would like to say that really diabetes as such, it is a real menace. It is a chronic situation which has taken the dimension of pandemic. And if you really see the Indian population, the International Diabetic Federation report from the 2020 has already established the fact that India is the epicenter of diabetic patients, and it harbors second largest population of diabetic patients, up to almost like a 77 to 80 million patients, diabetics. They are from the Southeast Asia. They are in India. This is the second next to China. It poses a great comorbidity for the cardiovascular illness, as you have already heard from Dr. Ajay Pandey, because it can form almost like a 50% of those patients. In the heart failure patients, the diabetes may be a comorbidity. If you really see the socioeconomic burden of this particular entity, this is a disease which does not really has any predilection, specific predilection for patient with any ethnicity or any monetary group. So anybody can be affected with this disease, and it poses a huge economic burden in Indian population. The reason being that if you really see the individual or household uh, economic implication of this particular disease, the out of pocket expenses go enormously, and it can in fact lead to it can exhaust up to 5 to 25% of the share of household income in this managing this patient, if you have any member of his family who suffer with the diabetes. So diabetes, in fact, the reason being that you do not have lots of dearth of these insurance policies, uh, and the healthcare system is such in India that majority of the patient, they uh, they in fact self-finance themselves for treating this chronic illness. So it can be a huge problem. It can have it not only the comorbidities and also the mortality for these patients. Along with that, the disease they live with, it can have a huge economic implication. So it is a real health issue that has been addressed and that will be addressed by various speakers in the subsequent talk. So with this, I would, I would like to start this inaugural session, and I invite Amit to help me with this proceeding. अमित को ये करना है ना क्या plan please?
Harshji,
Yes.
please play the number.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
By Dr. Palvi Mishra. She's a well accomplished diabetologist. She's the only cardiologist which is in Panacea Hospital locally in Varanasi, and she has a huge inclination for academics and research because she's a editor of a quarterly online journal, and she's a member of European Society of Cardiology and Heart Failure. So with this introduction, I would like to invite Dr. Palvi Mishra to start her talk, and let's benefit with this information what she is going to provide us. And let's benefit with this.
Thank you, sir. Thank you for giving my introduction. So, Dr. Amit,
Dr. Palvi, can you unmute yourself, because I don't think we can hear you very well.
Okay. So,
okay, you are unmuted.
okay. So now I'm audible?
Yes, madam, you are audible now.
Okay.
Yes, you are. Okay. Yeah, go ahead.
Thank you, sir. Thank you for giving my introduction. So, Dr. Amit, can I share my screen?
Yes, ma'am. You can go ahead, ma'am.
So, my screen is visible?
Yeah, it is visible. Ma'am, please put it on full screen.
Okay, so please wait.
Yeah, it is on full screen now, ma'am.
Thank you. Thank you very much. First of all, I want to give my thanks to Dr. Amit for inviting me. So today my talk is on secondary prevention after acute coronary syndrome, novel therapy. So in my talk, I will discuss about the novel therapy. So cardiovascular disease are the #1 cause of death globally, and more people die annually from cardiovascular disease than from any other cause. An estimated 17.9 million people died from cardiovascular disease in 2016, representing around 31% of all global death. And of these deaths, 85% are due to heart attack and stroke. So it is very important to discuss over here. And over 3/4 of CVD death take place in low and middle income countries. Out of the 17 million premature deaths due to non-communicable diseases in 2015, 82% are in low and middle income countries and 37% are caused by cardiovascular disease. This slide shows the burden of cardiovascular disease in 2017. You can see that cardiovascular disease burden is the highest. And this shows the cardiovascular disease scenario in the world, and this is in India. So there is dramatic shift in death from younger to older and from communicable to non-communicable disease. But the good news is that in acute coronary syndrome, outcome have improved over the last 25 years. So from 1995 to 2010, we can see that the outcome has improved. In GRACE registry, it is seen that from hospital admission to 6 months and from hospital discharge to 6 month mortality rate after ACS. And there is substantial mortality between hospital discharge and 6 months, 6% of patient with NST segment elevation MI. And in hospital mortality is highest in ST segment STEMI, whereas post-discharge mortality is more due to NSTMI and unstable angina. Major adverse cardiovascular event after successful uncomplicated PCI in 697 patient with ACS is shown here, and same number of events that occurred in acute coronary syndrome patient treated invasively were related to non-culprit lesion as were related to culprit lesion. Long-term survival post-ACS is similar for ST segment elevation MI and NSTMI. This is the UK, Belgium, GRACE experience. So residual risk post-ACS, ACS outcome have improved nowadays. And event rates remain high post-ACS. Event rate can be predicted by GRACE and other risk score. GRACE score is very popular risk scoring system, and it is developed to predict the risk for in-hospital death and 6-month death. It is validated in independent data sets and expanded to include prediction of risk for death or MI. This is a validated prediction model for all form of ACS, means it is for ST segment elevation MI as well as for NST segment elevation MI. So what existing treatment strategy we have for prevention of major adverse cardiovascular event? Lifestyle changes, medical therapy, and antithrombotic therapy. In lifestyle changes, we advise for smoking cessation, regular exercise, healthy diet, weight management, and psychosocial support. In medical therapy, we advise for lipid control like statins, for hypertension control, ACE inhibitor, ARB, and other drugs, for diabetes control, insulin, and anti-glycemic drugs. And for prevention of blood clot formation or any ruptured or eroded atherosclerotic plate, we advise antithrombotic therapy, single antiplatelet therapy with aspirin or clopidogrel. When patient comes to hospital with acute coronary syndrome, then we give acute care. We search for unknown or suboptimal control risk factor, and we initiate a standard secondary prevention. Initially, when we manage acute condition, after that we plan and schedule cardiac rehabilitation, we educate and advise, and we give secondary prevention therapy in the form of antithrombotic therapy, lipid lowering therapy, blood pressure, and glucose control. In antithrombotic therapy, we give aspirin plus P2Y12 inhibitor for 12 months. We give high intensity statin therapy We give ACE inhibitor, ARB, beta blocker, and mineralocorticoid receptor antagonist. We give glucose, for glucose control, we give metformin and insulin. And then we evaluate lifestyle, control of risk factor, complication with medication, and adjustment of secondary prevention therapy. So what we can give more, so we can prolong P2Y12 inhibitor therapy. We can give anticoagulants. For lipid control, we can add ezetimibe or PCSK9 inhibitor. For blood pressure control, LVH or heart failure presentation, we can do dose adjustment of ARNI. And for glucose control with cardiovascular disease, we can give SGLT2 inhibitor and GLP-1 agonist. Now we will discuss I will discuss in this presentation about all these novel therapy. So in spite of standard care treatment of post-ACS patient, there is mortality around 20%. Means there is some residual cardiac risk which should be filled by novel approach. And it can be further lowering of LDL cholesterol, more potent antithrombotic therapy, triglyceride control, inflammation control, type 2 diabetes mellitus with CVD treatment by GLP-1 and SGLT2 inhibitor, and through cardiac rehabilitation. So what are the novel therapy? For LDL lowering, there is a drug called as ezetimibe, and this is proven by IMPROVE trial, PCSK9 inhibitor, for FOURIER and ODYSSES trial. To reduce inflammation, we can use canacolumab, CANTOS trial, colchicine, COLO trial, and LODOCO-2 trial. To reduce thrombosis, we can use rivaroxaban plus aspirin, COMPASS trial. There is one trial in acute coronary syndrome, Atlas 2 TIMI52, by miscellaneous mechanism, like in diabetic patient, liraglutide leader trial, EMPARES trial, SUSTAIN 6, HARMONY, REWIND, and now PIONEER 6. And to reduce triglyceride, we can give icosapent-ethyl reduced trial, a very popular trial. So now we'll discuss IMPROVE trial. IMPROVE is a multicentric double-blind randomized study. And here there they have taken post-ACS patient less than 10 days, and LDL cholesterol was less than 125 milligram per deciliter or less than 100 if on prior lipid lowering therapy. 18,144 subjects were taken, and they were divided into two groups. In one group, simvastatin 40 milligram given, and in another group, ezetimibe with simvastatin was given. And then they were followed up for 2.5 years. Then what is the outcome? There is a favorable outcome for primary as well as secondary outcome. And the result of landmark IMPROVE trial indicate that in patient post high-risk ACS, ezetimibe 10 mg with simvastatin 40 mg is superior to simvastatin 40 mg alone in reducing cardiovascular event. Second point, a reduction was observed in first as well as recurrent event, and patient with diabetes mellitus, prior stroke, and prior CAGB appear to have a greater treatment effect than patient without diabetes mellitus. Interestingly, there was no increase in the incidence of new onset diabetes mellitus like statin as observed with statin therapy. And this is the first study powered for clinical outcome to show a benefit with non-statin agent when added to statin. So in high-risk group, we can add this drug, or when our LDL target is not fulfilled, then we can add this ezetimibe drug. And this is actually good for diabetes patient, for prior stroke patient, and prior CABG patient. So the addition of ezetimibe to simvastatin in patient stabilized after acute coronary syndrome reduces the frequency of ischemic stroke with a particularly large effect seen in patient with prior stroke. So this drug is very important, and we use nowadays this drug very frequently. Now PCSK9 inhibitor. So we'll discuss FOURIER trial. So what is actually PCSK9 inhibitor? You can see that this is the LDL cholesterol, and this is LDL receptor. So once LDL binds to LDL receptor, then it invaginates, and it is internalized into coated endocytic vesicles that forms endosomes. LDL dissociates from LDL receptor, and LDL receptor is recycled on the cell surface. PCSK9 directly bind the EGFA domain of LDL receptor, here you can see, and targets LDL receptor towards intracellular degradation. So what it actually cause intracellular degradation of the LDL receptor. So PCSK9 inhibitor prevent degradation of LDL receptor. So in this manner, it decreases LDL cholesterol. So PCSK9 actually decreases LDL cholesterol very effectively. And in FOURIER trial, actually established cardiovascular disease, chronic established cardiovascular disease patients were taken who have prior MI, prior stroke, or symptomatic peripheral arterial disease. There were 27,000 patients were taken. So this is very large data. And then LDL cholesterol is more than 70 or non-HDL is more than 100. They were randomized, and in one arm, evolocumab was given, in one arm was placebo. They were followed for 12 weeks. And what is the summary? This evolocumab has decreased LDL cholesterol by 59%, consistent throughout duration of trial, and median achieved LDL cholesterol of 30 milligram per deciliter. Decreased CV outcome in patient already on statin therapy, and it is safe and well tolerated. In patient with known cardiovascular disease, PCSK9 inhibitor with evolocumab significantly and safely decreased major cardiovascular event when added to statin therapy. Benefit was achieved with lowering LDL cholesterol well below current target. Then this is the Odysseus trial. Odysseus trial was on acute ACS patient. After an ACS, outcome after an ACS during treatment with alirocumab. In this, the patients were randomized. This is randomized double-blind placebo-controlled trial, and patients were more than 40-year-old, ACS history within past 1 to 12 months on high-dose statin, inadequate control of lipid. Then alirocumab was given, and it has seen that in MACE there is significant outcome in myocardial infarction, in ischemic stroke, in all-cause mortality, and LDL reduction. So this drug is actually this drug has given result in all these parameters. What is reduced trial? So reduced trial is reduction of cardiovascular event with icosapent-ethyl intervention trial. In this trial, 8,000 subjects were taken, and the inclusion criteria was men and women more than 45-year age with established CHD, atherogenic dyslipidemia. Then what is the result? The reduced trial shows that use of icosapent-ethyl 2 gram twice daily was superior to placebo in reducing triglyceride, CV events, and CV death among patients with high triglyceride and either known CV disease or those at high risk of developing it, and who were already on a statin therapy with relatively well-controlled LDL cholesterol. Means LDL cholesterol was well-controlled, and this drug has targeted triglyceride. Reduced trial showed that lower ischemic event mortality with improved triglyceride. AF and serious bleeding were the side effect of this drug, and results contrast with other trials showing no CV benefit with omega-3 fatty acid. Now, residual thrombotic risk. Dual antiplatelet therapy is gold standard after ACS as per guideline, we all know. And now ACC guideline says that period should be given for 12 months, and sometimes it can be extended up to 3 years. And best dual antiplatelet is aspirin and prasugrel in combination. Then they utilized warfarin in place of P2Y12 drug inhibitors, and it is seen that there is reduced ischemic event in patient with prior MI, but with increased bleeding. So what is the optimum dose of new oral anticoagulant after ACS? So Atlas ACS TIMI46 trial was done, in which large dose finding study in 3491 patient with recent ACS, and in this trial rivaroxaban 2.5 milligram and 5 milligram was used, and it is seen that rivaroxaban 2.5 milligram is actually vascular dose, and 5 milligram shows favorable efficacy in combination with aspirin alone or DAPT. Less bleeding with rivaroxaban 2.5 milligram than higher dose. So with rivaroxaban 2.5 milligram BD, there is less bleeding. Then Atlas ACS TIMI51 trial was conducted, in which rivaroxaban 2.5 milligram BID reduced cardiovascular event but increased bleeding risk versus placebo. Then apixaban 5 milligram was tried, but it was not a significant trial. Rivaroxaban and AS, when acetyl salicylic acid aspirin is used sequentially, then when used simultaneously, then they act synergistically, and they target synergistically, they target essential component of atherothrombosis. And this is actually the reason for using this in combination. And in then COMPASS trial comes, which is a very good trial, and we are using this drug nowadays for vascular protection for in stable coronary artery disease patient or in peripheral arterial disease patient. And this trial was done on 27,395 subjects, and in this they were divided into 3 groups, And in one group, rivaroxaban 2.5 milligram BD plus aspirin was given. In another group, rivaroxaban 5 milligram BD was given, and in third group, aspirin alone was given. And this trial was followed up for 3 to 4 years. And it is seen that for primary endpoint, rivaroxaban plus aspirin has given the favorable results. And the p-value is less than 0.0001. And in secondary outcome also, this has given a significant p-value. So primary efficacy and major bleeding landmark analysis, if we done, then we can see that rivaroxaban plus aspirin has given the favorable results in bleeding as well as for CV death and stroke. So net clinical benefit is significant. Compass conclusion, rivaroxaban 2.5 milligram BID plus aspirin 100 milligram OD was used, and it reduces cardiovascular death, stroke, and myocardial infarction. It increases major bleeding without a significant increase in fatal intracranial or critical organ bleeding. That means in 2.5 milligram dose, BID dose, rivaroxaban does not cause fatal bleeding. Only it causes minor bleeding, which can be managed. Provides a net clinical benefit, no significant benefit of rivaroxaban alone. Means it gives benefit when used with aspirin. Now we'll discuss about the inflammation. Inflammation has a very key role in atherosclerosis and coronary artery disease. There are cholesterol crystal, neutrophilic extracellular trap, erythropoietin flow, and hypoxia. This stimulate pro-IL-1 beta to change into the active IL-1 beta, then IL-1 beta change into the IL-6 in liver. It increases CRP level and PI1 fibrin level. And this is actually vascular inflammatory markers, and this causes different effects like nitric oxide and endothelin-1 release, chemokine, cytokine release, adhesion molecule release, macrophage activation, smooth muscle proliferation, vascular inflammation, endothelial dysfunction, and atherosclerosis. Means this change cause more atherosclerosis and coronary artery disease. So there are few drugs, anti-inflammatory drugs like canakinumab, which is a monoclonal antibody, and colchicine, which we utilize in the gout, and then low-dose methotrexate. So there are few trials done on these drugs. Okay, so this is CANTOS trial done on canakinumab. So Ritker Paul has done this this trial, and in this the hypothesis is there is residual cholesterol risk, so we can fulfill this with improved trial by utilizing ezetimibe, or Fourier and Odysseus trial by utilizing PCSK9. For residual inflammatory risk, what we can do, we don't have any treatment, so he utilized canakinumab, and it is seen that there is 39% reduction in hsCRP, no change in LDL cholesterol, but there is 15% reduction in major adverse cardiovascular event. So in CANTOS trial, there is greater risk reduction among those with greater hsCRP reduction is seen. Now COLCO trial. COLCO trial is on colchicine, and it is seen that among patients who suffered a recent myocardial infarction, low-dose colchicine was effective at preventing major adverse cardiovascular event compared with placebo. Benefit was primarily due to reduction in incidence of stroke and urgent hospitalization for unstable angina leading to revascularization. This was the actually primary endpoint for this trial, and they have seen the result in this aspect. Then LOGOTO 2 trial is presented recently in ESC 2020, and this is trial of low dose of colchicine in chronic coronary artery disease, and results were favorable in terms of primary and secondary endpoint, but unexpected all-cause mortality was high. More and large RCT are needed to clarify this. This is LOGOTO 2 trial summary. Now, especially issues in diabetic patient with coronary artery disease. Patient with diabetes mellitus and cardiovascular disease will benefit from innovative therapeutic options in coming year. Rather, nowadays we are utilizing this. Currently, clinical practice guidelines advise a multifactorial approach in patient with diabetes mellitus after an acute coronary syndrome, but no specific recommendation are available for glucose lowering. However, this could change substantially after the result of EMPARAGE, LEADER, SUSTAIN 6, HARMONY, and REWIND. And now, PIONEER 6, oral semaglutide. SGLT2 inhibitor modulate a range of factors related to cardiovascular risk. What it does, it decreases blood pressure, arterial stiffness, sympathetic nervous system activity, decreases weight, decreases visceral adiposity, decreases oxidative stress, decreases triglyceride, increases LDL little bit. decreases uric acid, decreases albuminuria, decreases glucose and insulin, and thus it is a cardioprotective. There is one trial on empagliflozin, EMPA outcome. In this trial, there is significantly lower rate of all-cause death, CV death, and heart failure hospitalization with empagliflozin. Then we can see that in empagliflozin, primary composite at endpoint, secondary composite endpoint, death from any cause. This drug has given favorable results in all these aspects, like primary composite endpoint, secondary composite endpoint, death from any cause, CV death, fatal or non-fatal MI, hospitalization for heart failure, or CV death. Then GLP-1 receptor agonist. What are the mechanism? Cardiovascular and metabolic. In cardiovascular, it decreases atherosclerosis, systolic BP, endothelial function, cardiac ischemia. And what it does in metabolic effect, it decreases insulin resistance, body weight, visceral fat, LDL cholesterol. It decreases LDL cholesterol, triglyceride, albuminuria. So there is one pleiotropic effect of GLP-1. GLP-1 are anti-inflammatory, yes, probably modifying gut microbiome. So we will discuss about the LEADER trial, which is a very large trial, and this trial has done on 9,340 patients, and this trial was shown that there is significantly lower rate of all-cause death and CV death with liraglutide. So we can see that in this slide. This drug has given favorable results in terms of primary composite endpoint, expanded composite endpoint, death from any cause, CV death, fatal or non-fatal MI, nephropathy. SUSTAIN 6. This trial was on semaglutide. So in this trial, we can see that except retinopathy complication and CV death and death from any cause, this has shown favorable results in all other parameters. In SUSTAIN 6, we have utilized injectable once a weekly semaglutide. Nowadays we have oral semaglutide also. Harmony trial. The result of this trial indicate that albiglutide is superior to placebo in improving glycemic control and reducing CV events in patients with type 2 diabetes and established atherosclerotic disease. This appeared to be driven by reduction in MI, rate of CV death, and stroke were similar. Approximately 75% of these patients were on background metformin and 60% on insulin. Similar salutary effect on CV outcome have been reported for two other GLP-1 agonists in their respective trial, liraglutide in LEADER and semaglutide in SUSTAIN 6. So what is the Harmony outcome? Albiglutide is superior to placebo, and its cardioprotective effect of albiglutide is independent of, this is very important, cardioprotective effect of albiglutide is independent of HbA1c, blood pressure, and body weight. Most of the times we think that cardioprotective effect is due to decrease in HbA1c, but here in Harmony trial with albiglutide, cardioprotective effect of this drug is independent of HbA1c, blood pressure, and body weight. Now rewind trial. Dulaglutide, GLP-1 agonist, is superior to placebo in improving glycemic control and decrease CV event. And these are really important findings and suggest that dulaglutide may need to be considered for management of type 2 diabetes mellitus in similar high-risk patient going forward. Then Pioneer 6 with oral semaglutide, this was for non-inferiority, and this trial has shown few effects, and it has shown effects in non-inferiority. Then this is the slide showing meta-analysis of all CVT trial of GLP-1, and the trials are Alexa, LEADER, SUSTAIN 6, Excel, Harmony, Rewind, Pioneer 6, and we can see that for fatal or non-fatal MI, LEADER, SUSTAIN 6, and Harmony. LEADER, SUSTAIN 6, and Harmony has given are showing the better results than other GLP-1. Now I will discuss about the cardiac rehabilitation. This is also very important. So for this, we should do routine clinical assessment. We should advise exercise training and physical activity counseling and supervision. It should be guided by exercise testing and occurring in hospital during initial phase. Promote lifestyle changes and cognitive behavioral strategies that help to incorporate changes into daily routine. And we should give psychosocial management by social support, by reducing stress and anxiety of the patient, treating depression and sexual dysfunction. So what are the key takeaway? Cardiovascular disease incidence is increasing both globally and in India. In spite of standard care treatment of acute coronary syndrome with DAPT, beta blocker, statin, and ACE inhibitor, there is residual cardiac risk of 20%. We should include novel therapy in the form of pharmacological as well as behavioral modification to cover this. In pharmacotherapy, 4 approaches are most promising: LDL lowering by ezetimibe, PCSK9 inhibitor; antithrombotic therapy, rivaroxaban plus aspirin; triglyceride lowering by icosapent targeting vascular inflammation by canakinumab, colchicine, or methotrexate; behavioral modification by involving team like psychologist, exercise trainer, dietitian, social worker, educator, etc. In special population like type 2 diabetes mellitus with CVD, newer anti-diabetic drug like SGLT2 inhibitor and GLP-1 receptor agonist, either used alone or in combination, are especially beneficial in secondary prevention of ACS. Thank you.
Thank you so much, Dr. Pallavi, for giving us this exhaustive and information about secondary prevention in the patient with the acute coronary syndrome. I just have a couple of questions from you, and subsequently we will see if Floor has any question from you. My first question is about when you use the cholesterol lowering agents like statin and other drugs, what is your target of achieving LDL? Because as per guideline, I understand it is less than 70. But sometimes when the patients are on a statin, I found the LDL may be as low as like a 30 or less than 50. Is anything to worry about that very low level of LDL when the patient are on statin for secondary prevention?
Sir, we target LDL for its faster, lower and lower level. Like first we target there should be reduction of 50% in LDL level, and it should be as fast as possible. So in nowadays, if patient have more LDL and because statin will take time to work. So we can even utilize this PCSK9 inhibitor if cost consideration is not there, then we can utilize this PCSK9 inhibitor because it reduces LDL level very fastly. And definitely we should give high dose statin in post ACS time.
Right. And my second question is about use of dual antiplatelet therapy for the patients who have had of stents. So what do you recommend? What is the duration of dual antiplatelet therapy? Do they need to continue on that for a subsequent, for a period? And can they discontinue both antiplatelet, or can they discontinue one of them when they continue after a period? So is there any guideline and recommendation on that? And what is your clinical practice?
So usually we give dual antiplatelet drugs for at least 1 year. And if patient is younger and there is a high risk patient, then we can give extended therapy also for 3 years, but it is not actually recommended. Recommended therapy is only for 1 year. After that, we can continue with aspirin.
So you continue the aspirin for lifelong?
Yes, sir, definitely.
All right. So my another last question is about
Sir,
this
after 1 year,
glycemic.
Sir, one thing I want to tell you. Sir,
Sure.
after 1 year,
Yeah.
what we can do, we can add this, we can utilize this COMPASS trial information, and we can add rivaroxaban plus aspirin. This can be also one strategy.
Okay. And my last question is about the glycemic control for the patient who are diabetic and for secondary prevention. You are using newer generation of oral anticoagulants like SGLT2 inhibitors or even GLP-1 receptor antagonists. I really love these medicines because they have all the benefits that you are looking for. Because not only they reduce they achieve a good glycemic control. They knock out the HbA1c level. Also, they reduce the visceral fat. also reduces the body weight. And so, do you have a preference on one over other, SGLT2 inhibitor over GLP-1 receptor antagonist?
Because means ACS is due to atherosclerosis, so I will prefer GLP-1 receptor agonist or SGLT2 inhibitor. But if heart failure component is there, then we can definitely utilize SGLT2 inhibitor.
Okay. Thank you so much, Dr. Palvi. It was a brilliant talk, and we really all enjoyed it. Now, for the subsequent,
Thank you very much.
I would invite Dr. Arvind Pandey to continue with this moderation of the sessions, and so I pass it on to Dr. Arvind. So, Dr. Arvind, over to you.
Dr. Arvind is not audible.
So welcome all. So for the next session, the presenter is Professor S.K. Singh. So he's I think there was no formal introduction can be done for him because he's my teacher as well during my MBBS. I had done my, he was also my teacher. So Professor S.K. Singh has completed his DM in endocrinology in 1988 from Institute of Medical Sciences, Banaras University, Varanasi. And currently, he is the professor and head of the department Endocrinology and Metabolism, IMS-PHU. Sir was former president and vice president and secretary of Endocrine Society of India and president of Endocrine Society of India in year 2017. He is a professor in Department of Endocrinology since 2003. He had also done his fellowships in European Commission in INSN, European Commission fellowships with 161 publications, 75 international and 86 in national journals. He's a principal investigator in ICMR and various UGC projects. Sir will give his presentation, and the topic for the presentation is pragmatic approach to basal insulin therapy in the management of type 2 diabetes mellitus. So I invite Professor S.K. Singh, sir, for the same. Please welcome, sir.
Okay, thank you, Dr. Arvind. Thank you for my kind introduction, and thanks to Sanofi for giving this opportunity to interact you all. They have assigned me a topic, in fact, and this is my disclosure that Sanofi has supported to deliver this talk to you. A pragmatic approach to basal insulin therapy in management of type 2 diabetes. And in next 20 minutes, I would share with this message how to use basal insulin, how to titrate, what insulin to choose, what is the right dose to initiate basal insulin, how to optimize basal insulin, up to what dose, effect of basal insulin regimen on postprandial, cost of therapy, basal versus premix, which is very commonly prescribed, and what next after basal insulin. So I will be a little quick because we are already having so many topics covered, and therefore, okay, it's not allowing me to change the slide. Okay, so which insulin to choose at initiation? And this actually shows that most of the international guidelines and also the national guidelines have uniform recommendation for use of basal insulin at initiation if you have to initiate insulin. So look at this chart. ADA-ESD 2018 has supported basal insulin. 2017 IDF initially supported the NPH insulin, but then ultimately they also believed that basal insulin would be a good starter. Canadian Diabetes Association, UK NICE guidelines, RSDI Indian guidelines, Cardiology Society, and ADA and American Association of Clinical Endocrinologists 2020, they have changed their view for choosing the insulin therapy. And uniformly, every guideline has suggested that basal insulin should be a preferred insulin to start with. So initiating insulin in type 2, what are the situations you will need to start insulin? When two oral anti-diabetic agents are used maximally and you are not close to target for A1C, if there is an increased hyperglycemic symptoms like polyuria, polydipsia, and weight loss, if A1C is still soaring above 7%, significant insulinopenia means the person doesn't have enough of insulin in his body, and therefore the body weight will be less. So he's losing body weight, and the BMI is usually lower than even the ideal body weight. And duration of diabetes had been more than 5 years, and therefore they will have insulinopenia. So these are the situations where you need to start insulin. Otherwise, it is very difficult to achieve the A1C to target. This is one study implementing new strategy with insulin glargine for hyperglycemia treatment called INSIGHT study. And in this study, they compared the two groups. One was started with basal insulin glargine with OAD. The other group, they have assorted two other oral anti-diabetic agents when patient didn't reach the glycemic target. So they have included 405 patients altogether in run-in phase and 206 in one arm and 199. So they optimize oral hypoglycemic agents in the second arm. In the first arm, basal insulin glargine once daily at bedtime along with the existing oral hypoglycemic agents. And insulin was initiated at dose of 10 unit per day, and it was increased by 1 unit per day until achieving fasting target of less than 100 milligram per dl. What happened after 24 weeks? You look at this cartoon showing that A1C was lowered far better, minus 1.55 in glargine plus OID group, then OID optimized to the tolerated dose, and the A1C lowering was 1.2%. So we have a definite superiority of adding basal insulin along with OID, then increasing the other oral antidiabetic agents in achieving the target. The secondary outcome that less than 7% of A1C lowering in was more or in majority on those who were on glargine plus OID than who were on oral agents only. This is the insulin requirement in type 2 diabetes and inevitability sooner than later. Now, what this slide says that ultimately most of the patients will require insulin therapy, and I'm not saying all of the patients will require insulin therapy, and this is the 6th year most type 2 diabetic patients actually end up on insulin. And the reason was they had other comorbidities. For example, either they have myocardial infarction, heart failure, CKD, peripheral neuropathy, stroke, lower extremity amputation, proliferative diabetic retinopathy, and all-cause mortality. So these are the situations where the insulin was actually required in them for controlling A1C. So what is the right dose to initiate basal insulin and how to optimize? I think we can learn this mathematics very simple, that if the weight is 60 kg or 80 kg or 100 kg and you need to start glargine, you start with 0.2 unit per kg body weight if A1C is 8%. If A1C is more than 9%, you start with 3 unit per kg body weight. So the dose will be 0.2 unit per kg body weight or 0.3 unit per kg body weight depending on the A1C level, 8% and 9%, irrespective of the body weight. The initiation dose is dosimetry is same, The only thing, the total dose which you will calculate will be different for 80 kg, of course, for a 100 kg person. And it could be something from 12 units to 30 units. But the deciding factor to choose this metric dose would be the A1C. Now, once you have chosen 10 units of basal insulin in any patient, you need to escalate the dose depending on the response. If the fasting sugar level is above 100, then every third day you better add 2 unit extra, so that you go on increasing it till you achieve the target of fasting sugar of less than 100 milligram. Now this titration is very important. You fix the fasting to 100 by increasing the dose of glargine every third day. Why third day? Because you have to see that they reach the steady state of insulin kinetic, and then sugar level is the maximum effect of insulin has occurred. Then only you need to modify the dose if it is not close to 100 milligram fasting. The simple titration algorithm to titrate basal insulin have been given by various agencies. ADA, which takes into account the large population of diabetic patients, they say that increase 2 units every third day till the pre-decided fasting target is achieved, and decrease by 10 to 20% if there is a hypoglycemia. AIS and American College of Endocrinology, they have also suggested that you can continue with 2 units every 2 to 3 days, but they have also given a mathematical formula that if the fasting is between 110 to 139, increase by 1 unit, 140 to 180 increase by 10% of the total daily dose, and 20% total daily dose if the fasting is more than 180. RSDI obviously has also chosen the same, that as American College of Endocrinology, that should be preferred. RSDI, ESI have also suggested that same. And I will also explain why this figure mathematical calculation is also required. Why not simply follow that 2 units every third day, you go on increasing and you achieve the target. Now, if you follow if you have given the instruction to your patients, so patient-centric dose adjustment would be, as I said, very simple, that every third day increase by 2 units and achieve the target of fasting blood glucose. But if it is a physician-led titration, means physician is involved in titrating, physician can take extra precaution, and if the fasting is more than 180, increase by 8 units. Between 140 to 86 unit, 120 to 44 unit, and 100 to 122 units. Because you know what you are doing and patient will follow it. However, if the patient has to modify or up titrate the dose, let him do it slowly by increasing 2 units, and that is very comfortable. Otherwise, they might jump to some value. Sometimes they can increase up to 10 unit and they may have hypoglycemia. So you have to make a check. You have to put a check on them by following these the guidelines. So both way we can practice. I normally recommend to all of my patients to up titrate by 2 units simply every time they see that fasting is above 100. But when they phone me and I'm involved, then I look at the fasting value and I take liberty of escalating the dose a little faster by giving 4 unit or 6 unit at a time. Now, if A1C above the target, add basal insulin, that is ADA guideline, and the usual dose is 10 unit or 1 to 2.1 to 2 unit per kg per day, and set the fasting goal. You have to fix it. Many times, usually it is 100, but you can keep it 100 to 120 also, depending on the age of the patient and how he's living, and choose evidence-based titration algorithm. As we have already said, the 2 unit works very well. For hypoglycemia, determine cause. If no clear reason, lower the dose of insulin by 10 to 20%. Many times patients have cause of hypoglycemia, either they miss the meal or they do very hard exercise, physical activity, or they sometimes take other medications and they develop hypoglycemia. So if the cause is not known, it's better to reduce the dose of insulin. Despite adequately titrated basal analog, or bedtime NPH can also be, as it has been done earlier. NPH was the basal insulin for us in our time, but then this insulin is far better than NPH now. So once basal dose is more than 0.5 unit per kg, the target, you have to see that postprandial sugar is also controlled. And for that, you need to add prandial insulin. So maximum dose of basal insulin should be around 5.5 unit per kg body weight in a given case. And if there is a need to increase it, you also look at the postprandial sugar level and add postprandial prandial insulin. And if still the target is not achieved, the fasting is high, you can further increase the dose of basal insulin above 5.5 unit per kg body weight. But in that case, you first try this method of adding prandial insulin with the basal insulin. So what to do with other medication when basal insulins are initiated? When basal insulin is added, provided no contraindication to continue use of metformin, you continue it. Probably continue incretin based therapy along with this or SGLT2 inhibitor. Reduce glitazones if it is ongoing, and most recommend continue sulfonylurea therapy, but discontinue if hypoglycemia occurs or the sugar level is still high. You can continue the same dose of sulfonylurea or reduce the dose of sulfonylurea. So basal insulin, bigonides, you can add sulfonylurea, you can add alpha glucosidase inhibitor, glitazones, or you can add DP4 inhibitor or SGLT2 inhibitors. So you have choices of combining these. You can continue bigonides along with sulfonylurea or bigonides with alpha glucosidase or any of these combination along with basal insulin. And the goal is to fix the fasting level to target. So what would be the effect of basal insulin on postprandial? This cartoon actually gives a good idea what will happen if the fasting glucose is brought down. The fasting sugar level is also maintained due to hepatic glucose output or hepatic glucose production in the fasting state. So you have a normal fasting blood glucose, but then increase hepatic glucose production uh, adds to the level of fasting blood glucose. Now, if you check this rise of fasting blood glucose or reduce the hepatic glucose output by adding basal insulin, you knock off this effect, and the postprandial peaks occurring after each meal will definitely be reduced. So this is how the postprandial glucose excretion is reduced when you remove the fasting sugar level in that individual. So basal insulin normalizes fasting and reduces postprandial glucose excursion. And this cartoon actually showing that elevated fasting glucose with large postprandial excursion. The fasting was 120, 220, and when patient takes meal, this will further add to 130. So you guess 220 to 130 will be 350. So that will be the peak. But if the fasting by basal insulin, if you reduce to 85, fasting is normalized to 100, and then then after taking meals, the glycemic excursion will be close to 180. So something 85. So you have rise of 85 milligram only when the fasting is 100. But when the fasting is 220, the excursion will be 130 and it will be quite high, 350. So the advantage of reducing the fasting will be that it finally also impacts the postprandial glycemic excretion following meals, and that is the importance. Now we should also remember, and we have heard many times, that when the sugar level, when the A1C is close to the normal, or between, say, between 9 to 8 to 7, then the postprandial contributes too much. However, you should also remember that the 76% contribution is from the fasting and 24% contribution is from the postprandial when the A1C is close to the target. And when the A1C is far away from the target, the contribution of postprandial reduces and the contribution of fasting sugar is more. You must have remembered the other type of diagram showing that the early stage, the postprandial sugar contributes to A1C, and in advanced stage of the disease, fasting contributes to A1C. But overall, if you look at this figure, that speaks that the fasting is still responsible for elevated A1C, whether you are close to target or away from the target, but the contribution increases as the fasting, as the A1C goes up away from the target, is that of fasting. So overall, if you target at lowering of fasting, you expect there would be benefit in terms of reduction in the postprandial. So glargine is effective in bringing down fasting and postprandial with low risk of hypoglycemia and also the weight gain. And this is one study, initiative study, in which they have compared with bias, which is a combination of short-acting insulin and the basal insulin, and the glargine combination was with OHA. And what they have shown that the plasma glucose lowering was almost comparable in both these two, but the risk of hypoglycemia was more with the bias than with the glargine. Obviously, we are not giving short-acting insulin, so we don't expect that frequent risk of hypoglycemia with glargine and oral anti-diabetic agents. So glargine lowers fasting by almost 130 milligram per DL in 28 weeks, little superior. Postprandial was also lowered by 180 milligram, but the risk of hypoglycemia, as you see, with premix insulin, it was higher, and the weight gain was also higher compared to the glargine, where the symptomatic hypoglycemia and weight gain both were statistically lower as compared to premix preparation. Significantly greater reduction in fasting and PP with insulin glargine versus premix. This is another study known as laptop study. In laptop study also, they compared premix insulin twice daily with insulin glargine and oral hypoglycemic agents. And this cartoon very clearly showing that baseline values in both the groups were almost similar. But at the end of the study, the group which received insulin plus OHA had actually shown better outcome than the group which received premix insulin twice a day. So, and this is another interesting study, Hammer and Clinch. Switching from premix 30/70 insulin to insulin glargine improves glycemic control, and this was another observational study. It's not a randomized trial or follow-up, but this is the observational study, and they have shown that 28% further reduction in postprandial when they switch to glargine, 30% further reduction in fasting, 1.1% further reduction in A1C, and 74% patients achieved A1C less than 7.5. Significant reduction in weight was observed because they had gained weight due to a pre-mixed insulin preparation which contained short-acting insulin, and with the fear of recurrent hypoglycemia, patient had put on more weight, and that was not there when glargine with OAD was added. So insulin glargine reduce risk of hypoglycemia and 50% lower risk of overall hypoglycemia with basal insulin. Odd ratio was 0.53. So altogether close to 47%, 50% patients didn't have that much hypoglycemia. And this is a comparison of IDEC ASP, which is again, IDEC is a basal insulin and short-acting insulin with OD glargine in OAD uncontrolled type 2 diabetic patients. So overall confirmed hypoglycemia was more with short-acting insulin added to basal insulin. Now one would argue about the cost of therapy. We have seen the merits of basal insulin and it is non-inferior to premixed preparation and less risk of hypoglycemia and very good to initiate and to up-titrate the dose of insulin. The concern is the cost. So overall, the Lantus cartridge cost around 2.5 unit per is rupees per unit. But average dose is usually around 28 to 51. Some of the study, like in initiate study, it went up to 51. And another study published A. Kumar Plus, where they have used up to 62 units average. So the cost calculated was 70 rupees when 28 unit average dose was used. And when it was a 3070 human insulin cartridge, which cost around 1 rupees per unit, average dose was 64, the cost was 64 rupees. Aspart definitely costlier, 2.3 rupees per unit. And average dose was 78 unit in the initiative study. So it cost around 181. I think this is more of a economist calculation of the insulin. Have taken the specific dose range and they have calculated. It may not be that relevant all times, but overall the cost doesn't seem to be that high when you are using up to 0.2 to 0.3 unit per kg body weight in majority of your patient. IDACASP is very costly, 3.4 rupees per unit, and if usual dose is 70, you get the figure of 240 rupees per day. So the cost should not be a major concern these days. And looking at the compliance, the ease of administration of basal insulin and combining with the other oral hypoglycemic agents. However, we have been using NPH. We still use NPH in most of our patients. It works very well. But then overall, as the cartoon which I showed to you, that overall postprandial control will not be that good if you use only NPH insulin at bedtime. So one can still argue that NPH insulin being cheaper can be added to oral anti-diabetic agents and one would get the fasting control. But then the overall impact of this preparation or NPH insulin, a single dose bedtime, may not have that much impact on postprandial and you need to add short-acting insulin. If you add short-acting, the risk of hypoglycemia is increased, as we have seen in those two previous study, laptop and so going to the algorithm, lifestyle changes plus metformin, and when it doesn't work, basal insulin and titrate. Then if the requirement is more than 0.5 unit per kg or the target is not achievable, you add short-acting basal plus with the major meal and basal bolus when this is also not working as the beta cell function deteriorates over time in type 2 diabetes. So you have to be dynamic in your approach to control sugar. So rationale for use of basal plus regimen allows for a step-by-step approach for insulin intensification, delays progression to a full basal bolus insulin replacement that is also added. So you go to step by step and overcoming the inertia of initiating insulin and achieving the target very well with this, that improves the compliance and the confidence of the patient. So ADA 2020 recommendation for intensification with if above A1C target, despite adequately titrated basal analog or bedtime NPH or once basal dose, add prandial insulin, rapid acting insulin. Prandial insulin will be rapid acting insulin, which could be 4 unit a day or 10% of the basal dose. If A1C is less than 8%, consider lowering the basal dose by 4 unit or day or by 10% of the basal dose. So this is how you titrate, adding the basal plus, and increase dose by 1 to 2 unit or 10 to 15% twice, or for hypoglycemia determine the cause. If no clear region, lower the corresponding dose by 10 to 20%. Corresponding dose, one has to remember, the corresponding dose would be, if the morning dose has caused hypoglycemia, you reduce the morning dose. You don't reduce the next due dose because that has not caused hypoglycemia. There is a tendency to chase the sugar level by most of your patients. That sugar was high, increase the dose. Sugar is low, decrease the dose. No, you modify the corresponding dose which has caused low sugar. Do not reduce the dose which is due next to the stage of hypoglycemia. For example, somebody has hypoglycemia in the morning, so do not decrease the dose of insulin in the evening. It is with lunch, suppose there is a hypoglycemia before lunch, decrease the dose in the morning. So this is how you modify the corresponding dose. I think I tried to cover. I'm sure there would be some questions, and it's better to discuss the topic because many things are not that factual in this. Okay.
Thank you very much, sir. Thank you very much, sir, for such a comprehensive presentation. It was it's a very vast topic, and you had it nicely. There are 2-3 questions. One is that there are subset of patients who are non-diabetic, but whenever we plan for any surgical procedure, or then they might develop stress-induced hypoglycemia. Normally, it stays for 4 to 6 weeks, but these patients. So, how to manage these patients in post-operative phase, because they will mimic. They will have all the features of hypoglycemia, raised sugar levels, and all. So, how to manage the stress-induced hypoglycemia in post-operative phase?
That's a good question. Yep. Stress-induced hypoglycemia or in-hospital hyperglycemia is a condition. Many of patients are not known to have diabetes, or they have not been detected even though they had diabetes, but they are detected only during your hospitalization or procedure you are planning.
Yes, sir.
So in this case, you have to get the HbA1c done. You can order HbA1c. The HbA1c high suggests that patient had diabetes earlier. And if HbA1c is close to 7, 6.5, and sugar level is very high, it means that patient has stress-induced hyperglycemia. Whatever the situation, whether it is stress-induced or it is pre-existing diabetes undetected, or it is hyperglycemia following detected diabetes, the treatment, the sugar level has to be brought to a normal range. And for that, you have to start insulin. So insulin is the treatment of choice in hospital patients. For most of your 99% of patients should receive insulin when they have hyperglycemia. If the sugar level is more than 180, you suspect that they have diabetes and in hospital hyperglycemia, and you need to treat it with insulin. So you start with the short-acting insulin. If sugar level is not very high, just 180, 200, you start with 4 units of insulin, short-acting insulin with each meal. If sugar level is 200, 250 and above, perhaps the short-acting insulin will not suffice. In that case, you need to give the basal insulin also. So you can give 3 short-acting insulin with meal and 1 basal insulin. If the patient is on IV fluid, then you have to give insulin infusion that can be started, and that will help in controlling per-operative and post-operative. But once patient starts taking oral feed, then you switch to short-acting insulin subcute and basal insulin along with that. If the fasting is controlled, you may not require basal insulin, and you just give short-acting or rapid-acting insulin with each meal. But as long the patient is on parenteral, you have to give insulin infusion. Now, if the patient is on TPN, total parenteral nutrition, or not taking meal, in that case, you have choices of both. Either you continue infusion, or you can give with each feed TPN. With each meal, you calculate what is the carbohydrate content, and according to that, you can roughly calculate that for 3 gram of carbohydrate, you give 1 unit of insulin. This is how you titrate, and that can be a supplemental insulin with each TPN infusion given. So this is how you can monitor. But insulin should be the treatment of choice in hospital patients.
Sir, good evening. I'm Dr. Amit Shrivastava from Apex Hospital. I'm a cardiac surgeon, sir. And we usually have, you were my teacher during MBBS time, sir. And it was very nice hearing you after such a long time, sir. Sir, I just want, we usually have acute decompensated heart failure patients in our ICU settings and who have blood sugar levels more than 500 and like that, 500, 600, something like that. Sir, you just talked about the concept of insulin infusion. How to manage these patients on insulin infusions? How frequently we need to check the blood sugar level of the patient? When to stop the insulin, blood sugar monitoring or insulin infusion? So that is my question.
Yeah, Amit, it's a good question. Sugar level is very high in ICU setting, so best way is to give insulin infusion. But you have to take few precautions. One is that you must see the electrolyte, the potassium level, because what happens if you give insulin, glucose comes down, but at the same time there will be shift of potassium from extra cellular compartment to intracellular compartment, and there would be hypokalemia. So you have to be very careful. The potassium level should be normal. If it is not normal, along with insulin infusion, you also try to cover up for potassium. So you must see that potassium level is in the range above 3.5, then only you start insulin. Now, insulin infusion can be started, and usual dose of insulin infusion depends what situation is, but usual dose is around approximately 1 to 2 unit per hour. That's the infusion rate. However, if somebody is very obese, they might have insulin resistance and requirement will go slightly up to 2 to 3 units.
Sorry to interrupt you, sir.
Yeah.
Sir, which type of insulin is to be used in insulin infusion, sir?
Good. It is always the short-acting insulin. So what you use is the soluble insulin. Short-acting insulins are soluble. Even the analogs, some of the analogs have also been used. For example, a Humalog. This can also be used, or no rapid. The aspart insulin can also be used for infusion. However, the best would be to give the rapid acting insulin. Never use the modified insulin, or like as I discussed, the basal insulin, glargine, or these kind of insulin, or even pre-mixed insulin. They should never be used in infusion. In infusion, it has to be short-acting insulin. So modified insulin, of course, is now becoming a choice, like Humalog, which is a Lispro insulin that can also be used. But still, we are very comfortable with the rapid acting insulin, because it is easy to titrate them. Rapid acting, it's soluble, it goes with, it has very acceptable pharmacokinetics when it is used with fluid, normal saline, or even sometimes you don't have the infusion pump available or the veins are not available, you can charge the dextrose solution with insulin and that can be infused. Right. So this is how you titrate. And then another important precaution you have to take when you are giving insulin, that if you are giving something extra, like as I said, that if you are giving TPN along with the infusion, or patient requires for many days hospitalized, in that case you have to increase the supplemental insulin. So you adjust the dose with each amount, each meal you increase the dose or give a bolus of supplemental insulin along with the constant infusion dose of insulin. So we have and then there is a third method also, correctional dose. We can use the correctional dose also. How much is the sugar response? Depending on that, you increase, and there you can follow the sliding scale for in adjusting the correctional dose.
Thank you, sir. One last question is that unfortunately we are all cardiac surgeons, so we'll always ask regarding post operative phase. So normal protocol is that we wait in immediate post-op period, we continue the insulin therapy, and many of these patients previously have a well-controlled sugar on oral hypoglycemic agent. So how long we have to, wait for oral hypoglycemics in post-op period? Number one. Number two, can we start in combination? Can we give combination of OHA in combination with insulin in post-op period immediately?
Yeah, not immediately. I would say that and also it is recommended that when patient wound has healed, there is no surgical stress on him, that is the time patient can be switched to oral agents. But as long there is a surgical stress in form of the still wound is healing, in the process of healing, you continue insulin because that helps in wound healing also. There have been earlier study on CTVS patients that wound gape is more in those who were on not very well controlled. So to avoid that gaping of wound, continue insulin. Now, after they are discharged home and or you are satisfied that there is no stress, they can be switched back to the dose of oral hypoglycemic agents. However, they have to be very careful depending on how much meal they are taking, how much quantity of food they are eating. That will decide that they can take the actual dose of the previous oral hypoglycemic agents, or you still continue the half of that dose and then gradually patient can up titrate. A combination of oral and insulin can also be a choice. As I said, that if you think that the patient's sugar level has not been under control pre-operatively, I think the oral agents will alone not help and you need to add the basal insulin along with oral hypoglycemic agent.
Sir, I have one more question, and I just wanted to ask this last question before we end this session. Sir, which are the situations, because I'm very comfortable in using long-acting insulins and short-acting insulins separately. But what are the situations where we can use premix insulins at its best?
As I said, that the pre-mixed has same efficacy as that of basal insulin or basal bolus or basal plus. The study have shown, in fact, this study, they have compared basal bolus with the pre-mixed, and they have shown that it is non-inferior to that one, but then risk of hypoglycemia were slightly higher in pre-mixed preparations. So younger patients who are not very well controlled and they can manage, the pre-mixed preparation would be fine. Those who cannot afford the costlier insulin will also be benefited. But as we have seen the calculation, if the requirement of premix preparations are also very high, I think one should give a trial of basal insulin with OHA. In older patients,
Thank you
best
very
would be
much.
to give basal insulin, not to switch to premix, because I said the risk of hypoglycemia would be better.
Uh,
Thank you very much, sir.
Dr. Amit, I have a question for Dr. S.K. Singh.
Please, sir.
Hello, Dr. Arvind.
Yeah, Dr. Ajay, please ask. Please ask.
Yes, sir. Recently, I was in diabetes with COVID patients, and where I had come across infusion of long-acting insulin also. So, is it recommended to give long-acting insulins like glargine as infusion forms, plus if we want to switch single bolus injection?
No,
How do we switch
never, never,
from
ever, never.
infusion to?
Okay, never ever use long acting or basal insulin infusion, because the idea of making basal insulin, one was that you prolong the duration of action of the insulin. Now, if you put it in the vascular compartment, that purpose will be forfeited. It is lost. What you do, you put it in the skin, in epidermal, in the subcutaneous space, and from there it is absorbed. Now, another thing, there is to achieve this quality, the molecule has been modified. The glargine has been modified. You see the other amino acids have been added to various part of the chain alpha and beta, and then they, to maintain it in a complex form, they have lowered the pH of the insulin. So pH has been lowered,
एक
and
चम्मच वो देना गोभी एक चम्मच बस
so pH of the insulin is 3.5. Now imagine the pH is 3.5, and if you put it in the in the blood vessels, the pH is lost. And if it is lost, then the whole purpose of making it long acting will be lost. So you do not know what will happen to this insulin. It may behave like it is injected, given intravenous, and few minutes it is disappearing. So better not to, it should never be put intravenous or in infusion, as this molecule has been modified to make
Yeah, I heard this query because I saw long-acting insulin.
No, I think that is an error, and I would say it is typographical error, not the error by the doctor. So just forget it.
Yeah, my.
With permission from Dr. S.K. Singh, sir, I will like just add in this context
Please add as much as it could.
that Epidra is one insulin which has got tendency for the thrombosis inside the pump. So there are reports of pump thrombosis with the use of this agent. So as sir has rightly pointed out, there are molecular modification with these agents, the newer agents. So there can be problem. So certainly you have to use the regular insulin in the infusion.
Nice lesson.
Thank you very much. Thank you very much, sir, for the presentation. Now, the next speaker is also my respected sir, and he also needs no formal introduction. He's Professor Madhukar Rai, sir. Professor Rai has done his MBBS and MD and DM in endocrinology, and presently he is a professor of medicine and ex-head of the Department of Medicine in BHU Varanasi. Rai sir is a very respected teacher as well as research guide and mentor for a number of postgraduate and doctoral students. Dr. Madhukar was very instrumental in developing a state-of-the-art infectious disease research laboratory in the Department of Medicine in IMS BHU. He's a principal investigator in clinical and lab studies on leishmaniasis and on many other trials and research projects founded by esteemed organizations such as National Institute of Health USA, National Institute of Allergy and Infectious Diseases USA, the Infectious Disease Research Institute USA, the Bill and Melinda Gates Foundation USA, and European Commission and the World Health Organization. Dr. Rai had published over 50 research papers in national and international journals and contributed chapters to textbooks. He is co-editor of book on pediatric endocrinology and paper cited in one of the most widely read textbooks of medicine, Harrison's Principles of Internal Medicine's 16th edition. Dr. Rai has been on the organization committee of several medical conferences and is on the governing body of organizations such as Associations of Physicians of India and Endocrine Society of India. He's an invited faculty in various national and international conferences and delivered many lectures across the country and overseas. Rai sir will give his talk on insulin intensification on type 2 diabetes mellitus patients uncontrolled on basal insulin. So I invite Professor Madhukar Rai sir to proceed. Welcome, sir.
Thank you, Dr. Arvind, for those nice words. And should I start sharing the screen?
Yes, sir. Please, sir. Please, sir.
Okay. Is it visible?
Yeah, it's not now.
Not now?
No.
Okay.
Please.
Sir, press screen share button, then select your slide and then again press share button.
Yeah, I'm doing that.
Yeah, now it is coming. Sir.
Yeah. Yes.
So
yeah, now it's visible.
So I think good evening, everybody. And I think I heard somebody asking for ek chammach gobi ki sabji pass kar do. Somebody is sitting for dinner and listening to these lectures. It's pretty late. And I know surgeons have got a lot of endurance. And that is how they are enduring. My job has been made a lot more easier by the presentation of Professor S.K. Singh. And we know that when we have to insulin intensification in type 2 diabetes uncontrolled on basal insulin. So what Dr. S.K. Singh has done, that he has started on basal insulin. And if you look at the INITIATE study, you find that on basal insulin, about 40 to 50% of the patients will have a glycosylated hemoglobin to the target. He also mentioned that diabetes is a progressive disease. So it's not that you give a dose of insulin and then you can be sure that the patient will be controlled. It's a dynamic disease and you have to chase the insulin. And there are a few words which is now coming up. I think as a surgeon, you may not need it, but as a physician, we need to know that initially we used to talk in terms of blood sugar fasting and PP. Then we started talking in terms of fasting PP plus glycosylated hemoglobin, which needs to be controlled. Then, even after doing these three, we were not able to achieve the impact of glycemic control like a non-diabetic population. So we thought that there is a gap. And this gap was identified by what is called as a continuous blood glucose monitoring system, CGMS. And we found that, so after this CGMS was introduced, we started knowing that even the patient glycosylated hemoglobin is controlled, the patient blood sugar fluctuates a lot. And many times the patient is not controlled and there is a lot of fluctuation. With a given level of glycosylated hemoglobin, you will find that blood sugar swing is too high in one patient. In another patient, it is very like a normal person. And we started calling it as a glycemic variability. And this was added to another facet in the control of diabetes, With CGM, we also came to what is called as how much time you are in target. So now we have added that time in target. So these are new things which have come up, that if you are to control or intensify, you have to consider all these things. So this is a huge topic in itself, and maybe my surgeon's colleague will not like to hear all those things. So I will make it brief in a usual day-to-day practice. Another thing which is very important in the management of diabetes is, Professor S.K. Singh said that inertia in the diabetes management. It means we cannot, now we know that we have got a legacy effect. You control the blood sugar as early as possible and maintain it. The better the sugar is controlled in the early part of the diabetes, the better is the result on the complications to be followed. So as you have seen, that in order to achieve these targets, we are using a lot of anti-diabetic drugs, oral anti-diabetic drugs. And one thing which came out very clearly from the presentation of Professor S.K. Singh was that if the glycosylated hemoglobin is around 8 or more than 8, and the patient is on not controlled on 2 or 3 oral anti-diabetic drugs, the chances that he will be controlled further on escalating the dose of oral anti-diabetic drugs are only 30%. If you add a basal insulin, you control to 50 to 60%. Now still there will be 40% of the patients who will not be controlled, or these patients who are initially controlled will be losing control. And this is what we call it as the insulin intensification. So if you look at my flow of the presentation will be postprandial glycemic control, because you have controlled the fasting and now you have to smoothly control the postprandial glycemia. And what you can do is you can gradually intensify rather than jumping from one to another. You go from basal and you add one rapid acting insulin, and we call this regimen as basal plus. And we'll try to see that what is the impact of an analog, which we call it as a rapid acting insulin versus a regular human insulin. The regular human insulin has got a pharmacokinetic profile which is not very good to control the postprandial hyperglycemia, because it has got a blunt peak, and we got on almost physiological peak. So we will see what is the comparison between a regular human insulin and glulisine, and then we'll also try to see what is the benefit or advantage of using a glulisine or as a matter of fact a designer rapid acting insulin with the mealtime flexibility, with a special reference to glulisine. And then Professor Singh has very clearly compared basal plus versus premix strategies, and we'll put a little bit of light on that. So I will pass on very quickly. So postprandial glycemic control, how to overcome the challenges. Now, common challenges in controlling postprandial blood sugar is patient is, because you're taking meals frequently and you're too busy, so you are not adhering to your insulin regimens. It's very obvious that you're traveling and you are not able to adhere to your insulin regimen. You're skipping the meal, and so is the insulin dose, which is to be mixed, missed. And few people, like if you're in a party, you not like to inject yourself with insulin and then go for a meal. So this becomes embarrassing, or you start looking for a washroom where you can go and inject yourself with insulin. And it is also challenging to take the insulin at the same time every day. It makes your life tight jacketed, and then you tend to forget sometimes giving insulin. These are the problems which are encountered in the interview of 503 patients who were non-adherent to their insulin regimen. And this is the percentage-wise, what is the commonest cause. The typical algorithm, as Professor S.K. Singh was telling, that if you have added insulin, now you are starting with a basal analog. With analog, we mean to say that the gold standard analog is a glargine, U100, or you have got U300 now, and then you have got degludac. So if you are starting with this and you are starting with the initial dose of 0.1, whatever you are convenient with, and gradually up titrate, to a target. Now, if you are not able to achieve the target, you are not able to control the fasting blood sugar with a basal insulin of 0.5 unit per kg body weight, or if your fasting is at target, but glycosylated hemoglobin is high, then you think that the postprandial is elevated. So what we do is ask the patient to control his fasting with anything which is less than 0.5 unit per kg body weight of basal insulin. So you up titrate the dose, and you see me after 3 months once your fasting is controlled. Now, if this patient comes with a controlled fasting of around 100, but the glycosylated hemoglobin is high, then we start focusing on the prandial. So as you have seen that if you control fasting, another 25 to 30% contribution is by prandial insulin to the glycosylated hemoglobin. So if the fasting is controlled, it means the postprandial is adding to the blood sugar is adding, and you have to neutralize this prandial insulin. And the very simple algorithm is you start with neutralizing one meal with a 10% of the basal dose or 0.5 unit per day, whichever you are convenient with. And then you try to bring down the blood sugar. And if after this, the glycosylated hemoglobin is controlled, and this regimen is called as basal plus regimen, it is fine. If you are not able to do that, then you go for what is called as basal bolus. You tend to neutralize each of the meal. So what is essentially a diabetes management is realization that diabetes is a progressive disease where beta cell dysfunction is progressing. So you have to chase the target, and the targets are now multiple, from glycosylated hemoglobin to glycemic variation, then time to target and all those things. If you want to achieve actually like a non-diabetic population, and this could be done in a substantial number of patients on lifestyle, diet and oral drugs. If it is not controlled, don't delay, and you anticipate. What we call it is anticipate that this regimen, and anticipation is if glycosylated hemoglobin is more than 8.5 and the patient is not controlled on oral drugs, don't wait for another oral drug. Add basal insulin. Add basal insulin and keep on titrating. 1 unit per day, 2 unit every third day, and or a set algorithm weekly. Whatever algorithm you follow till you are able to control the fasting. Now, after fasting, controlling with the basal insulin fasting, you are also able to control glycosylated hemoglobin. You don't have to do anything. But if you find that with the basal insulin, you are not able to control the glycosylated hemoglobin, but fasting is controlled, start using basal plus, and then you neutralize each of the meal. So this is 1 meal neutralization with rapid insulin, and this is all meal neutralization. 3 meals or even 4 meals, you have to use basal insulin, basal bolus. So this is called as, so the rationale is we are following a step-by-step approach, and in that way the patient is getting used to, because this therapy is a lifelong therapy. It's not like a snapshot view. You have to follow this, and the patient has to be educated. And what we call it is a diabetes self-management. The patient has to be taught how to measure the blood sugar, how to up titrate the dose, how to down titrate the dose, what are the symptoms of hypoglycemia, and this we call it as a diabetes self-management. And then you have to don't delay in step up or step down approach. And if you could control it, you will delay the, if you are not doing it rapidly, you are delaying the progression to full basal bolus regimen. So the inertia should not be there. What is the concept of this basal plus? Because normally when you are taking a meal, so this is the contribution by the hepatic glucose output, and when you're taking the meal, what is happening is there is each meal associated. So if they are taking meal at this time, you are getting a prandial peak here. If you're taking a major meal here, you are getting a peak there. So in that way, what has been identified that every person has got a major meal. Out of all the meals you take, one meal is called as a major meal. And what is this major meal? A major meal is one where the glycemic excursions are maximum. And how do you identify it? The patient whose fasting is controlled, but glycosylated hemoglobin is high, you do a 7-point profile on the patient. You do a pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner, post dinner, and tries to see which of the excursion is the maximum. And then you neutralize that particular meal. And this is strategy is called as a Basal plus strategy. So you give the injection, and this injection is to be given in such a way that the peak of the insulin injection matches with the peak of the hyperglycemia, postprandial hyperglycemia. So this is the trick. And all the thing has been done because all the modifications in insulin has been done to make it appear and disappear like a normal prandial insulin. So insulin which comes into the circulation very quickly and disappears from the circulation very quickly. So initially it was human insulin. It was, if you see, it used to last in the circulation for a pretty long time. The rapid insulins, they disappear very quickly. So basal plus approach with insulin glargine and glulysin is another rapid acting insulin. Practical points are a fixed single bolus dose or 4 to 6 units administered. So this is one way, the largest meal. So you identify the largest meal and neutralize that meal with, initially you start with the 4 to 6 units, and then as the need be, you titrate the dose. Now, another way is a dose could be defined based on the level of ppg blood glucose. And a simple rule is you divide it by, you calculate the ppg blood sugar in millimoles and divide it by 2. And those who are using in milligram, you divide it by 36 because 18 for the molecular weight of the glucose. So this is another dose regimen. Another is, as Professor Singh has said, that take the 10% of the basal dose, whatever it is. Or another, so these are various algorithms, and you can pick up one of them with which you are comfortable, practice this algorithm, and then you become expert in this particular algorithm. So a dose based on patient weight, and this is 0.05 unit per kg body weight. Now, what is the difference between glulysin and regular human insulin and other rapid insulins? You see, this is a typical pharmacokinetic profile of a regular human insulin, which is given in 0.3 unit per kg body weight to a patient. At time 0 it is given, and it peaks at, if you see, around 2.5 to 3 hours. And then it remains in the circulation for almost 6 to 8 hours. So this is, we want it to peak within half an hour and then disappear from the circulation within 2 to 3 hours. So this, to achieve this, we have, there have been certain modifications are made, and these are called as designer rapid acting insulins. So what is happening is, if you are using regular human insulin, what you have to do is, to match this peak, the patient has to take insulin half an hour to 1 hour before the meal. So this is very difficult. These are the modifications. There are certain amino acids which have been tried: listro, aspart, and glulysin. So as you see, so these are certain amino acid modifications which are done to make the insulin rapid acting. And as a consequence of it, what happens that if you look at the at different dose, the pharmacokinetic changes. So what is happening is, if you look at this red, that is regular human insulin, you see the peak. It is going like this. It is lasting in the circulation for a very long time. What we want is a rapid appearance and disappearance, and this is happening with insulin glulysin or insulin aspart or other insulins which are rapid acting insulins. So this is the only advantage of using the regular insulin, this rapid acting insulin. And how much is the rapid acting insulin giving you, the patient, a freedom of giving the insulin with the meal? Like if the patient is to take regular insulin, he has to take this insulin about half an hour to 1 hour before initiating the meal. It means he pricks himself, and then half an hour to 1 hour after that, he starts taking the meal. Now, if he misses the meal or somehow or other he vomits out, there is a problem. Now the patient is definitely going to get into hypoglycemia. If you've got an insulin, which is, you see, area under the curve within 0 to 30 minutes. It shows the rapidity of insulin action. And if you look at blue lysine, 30% of the insulin comes within 30 minutes into the circulation as compared to aspart, which is 16%. And glucose insulin ratio maximum 10%, it is 9 and it is 17, and INS max is 3 versus 20. So it means that blue lysine gets into the circulation quickly and disappears from the circulation. It is almost 50% shorter median time than aspart. So what does it accrue to? It means that you've got a better mealtime flexibility. You can give this insulin just before the meal, just after the meal. So you've got a lot of time window. So who are the persons who are very difficult in taking meals? Children. You don't know when they are going to take meal and how much they are going to take. I would prefer to give this child insulin once he's taken his meal. Elderly people who've got appetite problems, one day they're taking something, another day they're not taking, in hospitalized patients. Persons, doctors who have got a very busy lifestyle, they do not know, our cardiothoracic surgeon friends, they may be operating and they may not be taking insulin. So got a very busy and erratic lifestyle. And of course, if the pharmacodynamics is changed due to hepatic disease, which is causing clearance of insulin, as well as from the kidney disease. So these are the situations where you would like to have a rapid acting insulin, which you can give predictively once the patient has taken meal or just started the meal. Now, what is the window period? So if you look at the start of the meal, 15 minutes and 20 minutes. So if you can take insulin within this period, so this will add to, so if you've got liberty of taking insulin either any time in the 15 minutes or in the 20 minutes after the meal, so which insulin gives you that leeway? For blue lysine, you can give 15 minutes before the meal. For aspart, it is 5 to 10 minutes before the meal. Dispro, it is 15 minutes. Now, after start of a meal, if you are to take insulin, within what is the time frame, you can give within 20 minutes. Here we do not have any data, and here also we do not have data. So the total window period within which the patient can take insulin is 35 minutes. This is of very paramount practical importance, because unless you've got this type of flexibility, the patient will be confused at when to take insulin. And so this is a problem. So you are getting a 35-minute window within which you can inject the insulin, plus minus after the meals. Now, this is a study to say that basal plus regimen. And what is this basal plus regimen? Basal plus neutralizing one of the major meal. So whether this main meal concept or a major meal concept, or you only neutralize the breakfast. So there are two groups of patients whose blood sugar were not controlled and their breakfast was neutralized. Another was main meal was identified and that was neutralized. And a comparison was made between insulin blue lysine once daily at the breakfast with basal insulin glargine, or insulin blue lysine once daily with the main meal along with basal insulin. And what you see is there was, although it was not very, in both the situations, you find that the glycosylated hemoglobin dropped. In the breakfast group, 7.35 to 7, and in the main meal group, 7.29 to 6.94. So you find that there was significantly more decrease, but statistically it was almost not significant. So both were almost similar. So was the mean body weight gain, whether you are utilizing the breakfast meal or the main meal, was similar. What was the confirmed hypoglycemia? It was their breakfast or main meal, it was similar, no statistical difference. And severe hypoglycemia was again non-statistically significant. So it shows that you can either neutralize the breakfast or you can, but it's always better to neutralize the main meal. Now, this is another study. Somebody was asking, why not use a premix? You have got a premix. Now, the problem with premix is, the requirement of the basal insulin is 50%, and 50% is your bolus insulin. Now, if you are using a regimen in a premix, you give with the premise that if you are giving premix insulin at breakfast, you are covering for breakfast as well as for the lunch. This rapid acting insulin is able to take care of the breakfast, and long acting is going to take care of your lunch. Now, if at this particular time somebody misses the meal, or if you keep on increasing the dose of the insulin based on the rapid acting insulin action, your fasting will get deranged. So the flexibility of using the insulin will be lost if you are using a premix strategy. And precisely what happened, that if you are using a premix strategy, what you are getting is more hypoglycemia and more weight gain. And it is emphasized time and again that any of this regimen, insulin efficacy wise, is similar. What is important is safety and weight gain. So the better is the insulin, the safer is the insulin, and the weight gain is lesser hypoglycemia. And this is what is the advantage of using basal plus or basal bolus over premix insulin regimens. So if you compare basal plus, higher dosing, titration flexibility, you've got definitely a titration flexibility. You are separately titrating the fasting and separately titrating the prandial. What is happening is you are gradually introducing to multiple insulin injections. So the patient is gradually getting accustomed to insulin injection, cell blood glucose monitoring, and you are gradually teaching the patient with diabetes self-management. And of course, it has a higher glucose lowering efficacy. With premix, less dosing is there, but titration flexibility is also less. Your life is tight jacketed. You have to take a meal at a particular given time. Once you have injected a loose bullet in your body, and you have to move the target to capture that. Less effective glycemic control. These two are very, very important. Higher risk of hypoglycemia and a greater weight gain. So this is backed by number of studies. And among the basal bolus or a basal plus combination, the rapid acting insulin which is most studied is glargine, because this company has got both glargine and glulisine is there. So the glulisine is the most extensively studied rapid acting insulin in combination with a long acting insulin. So the key message is glycemic control is imperative to reduce the mortality, and especially in hospital setting. It is very, very important. And COVID era, you have to know what is how precisely you can handle the insulin, whether you are using with insulin pump, where you have to only use, as Dr. Ashutosh and Professor Singh has highlighted, rapid acting insulin. Don't use any analogs. They are cheaper, and if you are using one of those analogs, they are not going to add any extra benefit to it. Always intensify basal insulin in order to control postprandial sugars in the type 2 diabetes. So if you are to control overall blood sugar, intensify the basal insulin and then add basal plus and basal bolus as the need be. Rapid acting and long acting insulin analogs, we are in process of aiming to mimic the endogenous prandial peaks, which is not achieved by the pharmacokinetics of a regular human insulin. And a stepwise intensification of basal glargine with single injection of insulin glulisine can be considered in clinical practice. Not considered, it is a gold standard, and this is a way to, or is a gateway to intensification of the insulin regimen, by which the patient knows how to handle a rapid acting insulin and how to handle a basal insulin. With this, I would like to invite questions if there are any.
Thank you very much, sir, for this presentation. I'd like to have one question that how to manage the blood sugar fluctuation, especially in ICU settings.
In ICU setting, ICU setting is probably for me,
Hypoglycemia.
that's the easiest setting because problem with insulin is when the insulin is deposited in subcutaneous tissue. As a physician who is acting in an outdoor basis or in a ward, what we are doing, we are trying to give injection in the subcutaneous tissue and trying to match the normal physiological insulin delivery by giving it into the subcutaneous plane. And this goes in the blood. In ICU, what you are doing, you are using an intravenous infusion pump. It is in contrast to the subcutaneous infusion pump, which we are using in a patient in outdoor basis. So if you are using that, what you can do is, you have to simply match the glucose, hepatic glucose output, which is to be suppressed by insulin. And whenever the patient is taking meal, you need to increase the dose of insulin. And here, there is some concept which we call it as a correctional dose, right? And a total dose requirement, or we call it as like suppose the patient have got an approximately 30 units, like Professor Singh said, they start with 1 to 2 units per hour, right? If you're using infusion pump, you're using as 1 to 2 units per hour. And what you're finding is that patient blood sugar is not getting controlled in the target. You expect a fall in blood sugar. It is not, you increase the dose. Now, in the total dose is say 30 units, you divide by 500 divided by that particular unit, and 1 unit of insulin is going to neutralize that much amount of carbs, right? So in that way, every person, like I can neutralize like 15 grams of carb with 1 unit of insulin. You will be able to neutralize like 20 grams of carb. So every person's basal dose or total dose requirement gives a good idea as to what is going to be the insulin sensitivity of that particular patient. So that's one thing you can do. And so a frequent monitoring, if the patient is very stable, I will like to do the monitoring 3 to 4 hourly. But if the patient is very unstable, or till the patient becomes stable, I will like to do it 1 to 2 hourly. So monitoring is the key to success, and you have to give an algorithm to the sister in charge, because as a doctor, you're not going to do that. The nursing staff has to know the instruction that what is the insulin level, what is the insulin, and how much dose of the infusion is to be reduced, and what is the dose of to be increased. This instruction, and there are a lot of protocols which can be discussed in ICU setting, the Yale University protocol or some other protocol. One of the protocol you can follow, and this has to be a written statement to the nursing staff, how to up titrate and down titrate based on the blood sugar level. So it's very easy.
Thank you, sir. Sir, one more question I would like to ask, sir. Sir, there are some long-acting insulins available. That one is Lantus, which is glargine, sir. There are many other insulins.
Yeah.
Have more than glargine.
Yeah.
Hello.
Yeah.
Sir, there are some long-acting insulins available. One of them is glargine, which is Lantus, and there are some who have T-half more than glargine. So, how to decide which long-acting insulin to be used in as basal bolus?
You know what is the concept of this basal bolus is? The basal bolus concept is when you are giving a basal insulin, you in your body, whether you are eating or not, there is a constantly secretion of insulin in a pulsatile manner. What you have to do is, by giving the basal insulin, you have to match that basal insulin release. And this is, for this you need a peakless insulin. It means the insulin doesn't peaks. It gives a particular level and then it stabilizes at that particular level. So this is what is a basal insulin. And then when you eat, suddenly there is a spurt of insulin release, which mops up your postprandial. So precisely what we are trying to do is we are giving a subcutaneous injection to match the physiological peak, which we have not been able to do so far. So any basal insulin which is acting for more than 24 hours and it is peakless qualifies to be a basal insulin, right? For bolus insulin, it has to appear and disappear very rapidly. So any of the basal insulins, depending on the cost, because you have also to look into the cost considerations. Now we are going to get a weekly insulin, basal insulin. You give once a week. So maybe it will come because it will be very good for the patient. You create a depot. From that depot, insulin is gradually getting released in the required amount, in which and the patient has to take only once weekly injection. So as we are progressing, we are getting better and better insulins, and only time will tell. But as on today, the cost-effective insulin is Glargine, and it is almost has all advantages of the what is called as the third generation basal insulins. Indian context, if you look at the cost-wise comparison.
Thank you, sir. Just one more question that sometimes we see many patients who have very well controlled fasting blood sugar, but the postprandial blood sugar is very high without any oral hypoglycemic agents or insulin. So what we have to do in these cases?
You know, postprandial hyperglycemia is one fact is that if you are to develop diabetes, the first blood sugar which becomes abnormal is the postprandial, right? Secondly, postprandial is also a marker for cardiovascular disease. We have got a 140. If you see the range in which the sugar is resting is between 90 to 140. Your delta is only 50. The maximum is delta is only 50. But in a non-diabetic or impaired glucose tolerance, this peaks are becoming very high. So if you can contain it, one is you are taking cereal, which is complex cereal, which delays the absorption. You got certain drugs which can delay the absorption, like we have got alpha glucosidase inhibitors. So if the person has got only fasting, is normal and BP is increasing, what you can do is you can delay the absorption of glucose. One is that you make the meal very complex carbohydrate. Another is you do not allow it to absorb very quickly, right? And then once it gets into the circulation, you try to mop it up with a short dose of insulin if needed or some other drugs. So options are there. And essentially it is, you know, the physiology or you know how the drug is acting and how it is going to affect the system. And then you can automatically have a permutation and combination. And
sir,
one another thing I would like to point out here, that we talk a lot of about hypoglycemia. In our time, we had only two drugs, metformin and sulfonylurea.
That is true, sir. That is true.
Other than insulin. Now we have got drugs which can control the blood sugar without causing hypoglycemia, right? And these are, except for sulfonylurea, neticlinides, and insulin, none of these drugs are going to cause hypoglycemia. So you can use them very safely. Yeah.
Yes, sir. Sir, one more question, sir. What is, as a cardiac surgeon in ICU settings, I don't think, but in discharge settings, when the patient is being discharged, and what is the role of SMPG in our patients? Sir? How can we use SMPG in our patients?
You know, SMPG is of paramount importance. Every patient, if you want to delegate the patient, it is something like treating the patient blood pressure without measuring the blood pressure. So unless the patient, you have got a diary of self-monitored blood glucose and you try to correlate it with the glycosylated hemoglobin, it will be very difficult for you to know exactly what is the level. Second is, now this SMPG is being supplemented with what is called as CGM, continuous blood glucose monitoring system, where you can see like it is like ABPM. If you are measuring a blood pressure, almost half an hour every time for 24 hours, and a computer is going to integrate all the data for you. Similarly, is a continuous blood glucose monitoring system. And you know what is the variability and other things. So the tools are going to improve. Maybe you'll be wearing, patient will be wearing a watch and he can find everything, that his blood sugar fluctuations and all those things. The technology is advancing. But as on today, we have got self-monitoring of blood glucose, which makes the patient very efficient in handling his blood sugar. One is that whenever he gets a symptom of hypoglycemia, he can measure it. And frequently he measures, and you are only not measuring the post-breakfast, you're also measuring post-lunch, pre-lunch, post-dinner, bedtime. So at different times he's measuring a different point scale, and ultimately you know what is the integrated glycemic profile of the patient, which is very, very important.
So many times we have seen that we used to give large bolus doses for immediate control of hypoglycemia. So what's the role of these?
Never do that. Even in the patient management of, decay or hyperosmolar coma, we don't give large doses, right? There is no advantage of giving large doses. It is just a false sense, and it will create problems rather than it will solve the problem. So don't use high doses.
Sir, one last question from the audience, sir. Where has the oral insulin reached in current scenario? Oral insulin, because everyone is asking about oral insulin. कहाँ है वो? कहाँ है वो? So where has that reached?
अभी आएगा तो पता चल जाएगा. अभी नहीं पहुंचा है. अभी नैनो कैप्सूल में डाल करके उसको देंगे तो एब्जॉर्ब हो जाए, फिर जाके डिग्रेड हो, तो प्रोटीन है ना, ब्रेक कर जाता है. आशुतोष बताएगा. हाँ आशुतोष.
Yes, sir. We have written an article on our general card app Gen on oral insulin. Amit can refer to that, and there is one article in the Lancet.
पढ़ने मत दो, बताओ कि
sir, basically GLP-1 is one molecule which is a peptide. Now this peptide is available in the form of oral therapy. So it has shown a way towards the oral insulin. Certainly peptide can be absorbed orally. So that is one thing. But as you have rightly said, that certainly there are many hurdles in the oral insulin. So only time will tell when it will be available. But certainly this is a way ahead.
So can we call it a day?
Sir, basically I am the last batsman in this IPL.
Very good.
Thank you very much, sir, for this presentation. Now I'd like to invite Dr. Asutosh Mishra. He is also my respected senior. He had done his MBBS and MD medicine from Institute of Medical Sciences. He had done his fellowship in diabetes from CMC Vellore. He possesses a professional experience of over 19 years and as an endocrinologist and diabetologist. Currently, he is a consultant endocrinologist and diabetologist, Panisha Hospital, Varanasi. He is the head diabetes care organization, Varanasi, assistant professor, Panisha Institute of Interdisciplinary Research and Education, Varanasi, founder and national secretary, Care Divicon National Conference, founder and deputy editor, Cardiovision, and faculty, Global Alliance of Medical Education, that's GAME. He's also national coordinator, cardio diabetes.
Hello.
ex-assistant professor medicine, and I'm a really ex-member. Is a member of European Society of Endocrinology. So welcome, Dr. Ashutosh Mishra, sir, and kindly proceed, sir.
Okay. So I am audible. So let me try. Let me see whether I
Yeah,
will
sir. Yeah.
share my screen. Yes.
Uh, Have to start the screen sharing, boss.
Yes. Okay.
Screen sharing.
My screen is visible.
Yeah, sir, please put it on full screen. Perfect, sir.
Visible in full screen.
Yeah, visible and full screen, sir. Thank you, sir.
It's moving nicely. Okay. So in the IPL era, I am the last batsman, and before me, there are brilliant players like Sachin Tendulkar, Rahul Dravid, and Saurav Ganguly. So I must perform like MS Dhoni, and let's see where I am. So uh, there is two picture in front of you. One is the tree, and another is the Mangalyaan. Is there any relation between the two? Anybody from the audience can point it out? Is there any relation you can think of? Yes? Anyone? You can unmute and just uh, you can guess, have a wild guess. So if not, so I'm telling the answer. It is the Isaac Newton. So who discovered the uh, gravity, and with applying those principle we are on Mars. So this is the apple tree in front of the physics department where Isaac Newton used to work. So this is the story. So idea can change the life. So do the combination of the two things like apple bark and Gilia monster. How it can change the life? It can change the life of a diabetic patient to fairly good lifestyle with a longevity and cardiac protection as well as renal protection. So that is the combination. So like teamwork, if you are combining two rational things, there is always a good result. So I will be covering something about the uh, synergistic combination of GLP-1 receptor and the SGLT2 inhibitor, the epidemiology, the cardiorenal perspective, the physiology of SGLT2 inhibitor, and then cardiorenal perspective. And at the end, I will talk about some evidence, and I will try to finish it off quickly. And certainly, I'm not going to bore you people because dinner is waiting for you people. So, in spite of the all advancement, only less than 50% of the patient are able to achieve the glycemic target. So this is the story, and still we are in search of ideal drug, which ideal combination, which is having complementary effect, safe, durable, well tolerated, easy to administer, and cost effective. So is the GLP-1 and SGLT2 is that combination? Only time will tell. So let's talk about something, the physiology of GLP-1. So you can see here, the GLP-1 is the molecule which is responsible for the incretin effect. So there are the two molecules. One is the GLP-1 and another is GIP, responsible for the incretin effect. In diabetes, the GLP-1 response is deranged. So the GLP is one secretagogue, which is secreted from the L cell of the intestine in the proximal part, and glucose is one which causes secretion of this. But there are other nutrients also, like lipid, protein, you can see bile acid, so gut microbiota. So there are many other stimulus also which can stimulate the L cell, and there is secretion of GLP-1. And GLP-1 is secreted inside the blood vessels to have endocrine effect. It has got some paracrine effect also, and it can stimulate the afferent vagal nerve also. So it has got different action also. So endocrinology, It has got neurohormonal action as well as the paracrine action. And the important point is it can protect different organ which is likely to be damaged in type 2 diabetes, the brain, the heart, the liver, and it also improves the pancreatic function. So what else you need? So all the organ which are being affected in the diabetes can be protected. So you can see here, diabetes, a disorder where multiple organs are affected. So here is an agent which can protect your heart, your kidney, your adipose tissue biology, the skeletal muscle, and you can, I'm not going to the detail of all these things, but the thing is the multifaceted disease, the multifaceted intervention. So not only this, the GLP-1 is anti-inflammatory also. So like statin, this is also anti-inflammatory drug. And apart from being anti-inflammatory drug, it can also decrease the oxidized LDL. So this is also another information. So another part, how it decreases the inflammation. It decreases the inflammation of different organ, particularly of the heart. Okay. So not only the heart, the larger vessel, the medium sized vessel, and sometimes there are some evidence that it can affect the smaller vessel also. So in diabetes, in cardiology, we can divide it, the cardiovascular system into the heart, the larger vessel, the medium sized vessel, and the small vessel. And there are different agents which can modify the pathophysiological abnormality in this regard. And another important point is every vessel inside different organ may behave differently. Like your brain vessels are behaving differently. They may respond to one particular agent, they may not respond to another agent. Some agent which may be vasculoprotective for the other vessel may have some deleterious effect, like SGLT2 inhibitor. They have shown some warning sign in terms of brain vessels. So the GLP-1 receptor agonists, they are having widespread action. As Dr. Pallavi has already showed this slide, the GLP-1 is going to affect the cardiovascular as well as the metabolic part. And some of the effect is being mediated by ANP. So this is the molecule. The ANP molecule is secreted from the heart and responsible for the aldosterone-escape phenomena. So that is the reason the ANP is very important. So ANP may act on the vessel, on the kidney, the adipocyte to have protective effect. Okay. Not only this, the GLP is also having kidney protective action, both indirectly and directly. Apart from this, there is a communication between kidney and gut. So there is an incretin effect of sodium. So if you are giving GLP-1 to the patient, there is more and more sodium excretion into the urine. So sodium excreting capability of patient increase once you are giving GLP-1. So this is very important, particularly for the patient who are having volume overload. So this is an important part. Not only this, this is anti-atherosclerotic. This causes weight loss and hence renal protection. So in other terms, it decreases the renal inflammation. So in one review, nice review in the Nature's Nephrology, they have implicated 4 mechanisms. One, the very popular one, which the most of the time being quoted, that tubuloglomerular feedback, or you can say that the tubular intragranular hypertension. So this is the molecule which decreases the intragranular hypertension. Apart from this, it also improves the nitric oxide generation, as well as there is inhibition of RAS system and endothelial 1 receptor blockade also. So 2 of the mechanisms are acting on the afferent and 2 of the mechanisms are acting on the efferent vessel. So this is the 4 mechanism which is implicated, and as compared to SGLT2 inhibitor, you can see here the GLP-1 inhibit the renin, and this is why GLP-1 receptor agonists are more renoprotective as compared to SGLT2 inhibitor as far as pathophysiology is concerned, because it is acting on all four pathophysiological part related to glomerular hypertension. So these are the some direct and indirect effect why it is renoprotective. So main point is they decrease the intraglomerular hypertension and albuminuria is reduced. So these are the two main summary point, and that is the reason why the GLP-1 receptor agonist can be used well below the EGFR 30 up to the 15, and in harmony trial and some of the report with the liraglutide, it can be used well below the 15. So this is the agent which can be used in renal failure patient also without losing the efficacy on glycemic control. You all know that SGLT2 inhibitors are the agent who lose its efficacy once it is used in low EGFR patient. So this is very important aspect. Let's discuss something about the SGLT2 inhibitors. The SGLT2 inhibitor, you can see the mechanism of action. Again, SGLT2 inhibitors block the SGLT2. This increase the distal sodium delivery to the macula densa, which causes sodium loss and glucose loss. So in turn, the intraglomerular hypertension is corrected. There is weight loss and there is decreased HbA1c. So it goes without saying that SGLT2 inhibitor is reducing HbA1c, it is reducing weight, it is reducing blood pressure. So this is all different mechanism by which the SGLT2 inhibitor is acting. I'm not going into detail, but the main point is the SGLT2 inhibitors are cardioprotective, renoprotective, and liver protective also. This is a very important point. So in practice, you see the NFLD and NAS, it is very important. And some of the obese patient, you can see the gamma GGT is raised and the SGOTPT is raised. And if you do ultrasound, most of the time there is a fatty liver. So you want an agent which is cardio friendly, renal friendly, as well as the less torqued organ, that is liver friendly also. Okay. And it acts as a smart diuretics. It's only act on the interstitial fluid. So it is a smart diuretics. And because of this action, the luminal part is altered very less and there is no reflex neurohormonal activation. This is the beauty. But you should know how to start the SGLT2 inhibitor, how to increase the dose, what are different precautions. So it is very important. Sometimes over enthusiastic person with the full dose, with inappropriate time, with sick day schedule may lead to disastrous result, and altogether the patient may refuse the therapy. So not only this, there is favorable remodeling effect on the heart, and the glucose utilization in the heart and fatty acid utilization is increased, leading to more and more production of ATP. So mind you, this is not the ketone which is giving ATP. This is glucose and fatty acid. So alternate fuel hypothesis is not working. Probably the heart is salvaged by better metabolism of branch chain amino acid. The cardiac remodeling is favorably affected because of the decrease intramyocardial sodium and calcium. So there are early effect and late effect. So early effect means as early as 2 to 4 weeks. So there are so many favorable effects which SGLT2 inhibitors are having as far as heart is concerned. Not only this, the combination of the SGLT2 inhibitor and the AC inhibitor are very good for the kidney, and SGLT2 inhibitors are the agent which can reduce the intraglomerular hypertension. And you can see here in this figure, the dilated afferent arterioles, they are corrected once the intraglomerular hypertension is corrected, and more ketone alternative fuel is given to the kidney, and these failing hypoxic kidney, they will recover. So you can see here, this is the hypothesis. So these are the theory, but what about in the practice? In the practice, you can see the rate of decline of EGFR is stabilized. So this is certainly a renoprotective agent. What is the normal rate of decline of EGFR? This is 1 ml per meter square. So 1 ml per minute per meter square is the normal for the diabetic person. So cardiorenal protective effect of SGLT2 inhibitor, you can see here in this diagram. So there are many effects like reduction of weight, reduction of sugar, BP control, and you can see the sympathetic tone, the vascular tone. So all these are the good effects. So this is the theory, but what about the clinical utility and limitation? So looking at the cardiovascular protective effect of the SGLT2 inhibitor and GLP-1, the guidelines are now recommending that at least one of the guidelines from the AACE and ACE, which recommends that for a naive patient who is not receiving metformin, ahead of metformin, if that patient is having high risk for cardiovascular disease, very high risk or multiple cardiovascular risk factor with cardiovascular disease and CKD, you can use SGLT2 inhibitor or GLP-1 receptor agonist ahead of metformin. So this is very important change which is taking place. So for some group of patient, probably metformin is not a first line drug, and the crown of being a king as a first line drug is being challenged. And you can see here, those patients who are having metformin already, if they are having any CVD or CKD, you have choice like GLP-1 receptor agonist or the SGLT2 inhibitors. So if the disease is predominantly atherosclerotic predominance, you should use GLP-1 receptor agonist, as Dr. Pallavi has already highlighted. And if the patient is having predominant heart failure phenotype, the SGLT2 inhibitors are better agents. So according to the guideline, the type 2 diabetes without CVD with moderate CV risk, the metformin is the drug of choice. For high risk patient, the SGLT2 inhibitor and GLP-1 receptor agonist are drug of choice for the naive patient. And in case of CKD patient, if the EGFR is between 30 to 90, probably SGLT2 inhibitors are the better agent. If the EGFR is less than 30, then the liraglutide and semaglutide, the GLP-1 receptor agonist, are the better agent. So where to start the SGLT2 inhibitor? Somebody may ask how to choose between the SGLT2 inhibitor and GLP-1 receptor agonist. So if your patient is having CHF predominant disease or raised blood pressure, choose SGLT2 inhibitor. If you want to reduce the body weight in the long term and EGFR is less than 45, choose GLP-1 receptor agonist. And with caution, if your patient is having recurrent episode of genitourinary infection or tendency of insulinopenia or diabetic ketoacidosis, you should avoid SGLT2 inhibitor. While if your patient is having increased tendency of pancreatitis, diabetes, gastroparesis, and proliferative retinopathy, particularly in case of semaglutide, you should avoid GLP-1 receptor agonist. So starting an oral anti-diabetic drug is very simple, but it requires caution. It requires retinal examination also. So don't forget to examine the retina before starting any oral anti-diabetic agent, particularly the GLP-1 receptor agonist. So the comparison between the potential mechanism of CV benefit of SGLT2 inhibitor and GLP-1 receptor agonist, most of them are common, but something which I will like to point out is the myocardial and kidney benefit involving the metabolic effect and sympathetic tone, which is favorable for the SGLT2 inhibitor, while anti-inflammatory effect and LDL lowering cholesterol reduction effect is specific for GLP-1 receptor agonist. And as I have already told you people, that oxidized LDL is particularly modified by GLP-1 receptor agonist. So this may be a better agent. So here is the ominous octolect, and you can see SGLT2 inhibitor and GLP-1 receptor agonist, they are acting on different path, and if you combine them together, it can have additive effect, like you can see here in this slide. Okay, so if you are adding these two agents, there is more favorable effect. And look at this diagram. If you are using GLP-1 receptor agonist alone or SGLT2 inhibitor, and if you are using this in the combination, so you can see there are some effect like anti-atherosclerotic effect, the NFLD, inflammation, endothelial dysfunction. Probably in this aspect, the GLP-1 receptor agonists are better. They are having probably negative effect in terms of diabetic retinopathy, particularly for the semaglutide and for the heart failure. People think that for the heart failure, best drug is among the all oral anti-diabetic agent is the SGLT2 inhibitor, but the combination is much better as compared to SGLT2 alone. So the best drug is combination of GLP-1 receptor agonist and SGLT2 inhibitor. So here is the mechanism of action. And if you are combining these two agents, you can see there is additive effect and anti-inflammatory effect. The glucagon suppressive effect is negated, and you can see here the beta cell function improve, body weight reduce, uric acid, systolic blood pressure, risk of hypoglycemia, and weight. So as if you remember the first slide I have shown you, what the ideal oral anti-diabetic need. It should be potent enough to reduce HbA1c, it should reduce weight, it reduce BP, and there is no increased risk of hypoglycemia. So these all property are there with the GLP-1 receptor agonist and SGLT2 combination. So let's see what evidence says, because pathophysiology may not be proven in the trial. So let's talk about some of the landmark trials, randomized double-blind control trial. One is the Duration 8. The Duration 8 trial, in which the DAPA and the exenatide once weekly was given together. So this is a simultaneous start trial, of known as Duration 8 trial. And what this trial has given to us, that the combination is better than alone therapy in all parameters like controlling fasting, PP, weight. So in subgroup analysis also there is substantial benefit. So you can see without increasing any adverse effect, the drug is effective. So co-administration of the exenatide and DAPA, there is better effect. So this is the simultaneous start. That means exenatide and DAPA started simultaneously. So let's see sequential start. Sequential start means already there is one agent, and on top of one agent you are adding another one. So this is sequential start. And the trial is award 10, where dulaglutide was added to the existing SGLT2 inhibitor. All three SGLT2 inhibitors were included in this trial. And what they have shown, again, there is substantial benefit if you are adding SGLT2, dulaglutide to SGLT2 inhibitor. So if you are using GLP-1 on the top of SGLT2 inhibitor, there is favorable effect. Another sequential trial, that is Sustain 9, that is semaglutide added on to the existing SGLT2 inhibitor. Again, double-blind randomized placebo control trial across the different countries, 61 centers. And what they have shown that, again, the HbA1c reduction is more. Overall, patient who have achieved the HbA1c 7 is substantially improved the weight reduction, and overall weight loss more than 5%. That is the significant weight reduction. So that is also there with the combination therapy. So with the combination therapy, HbA1c reduction and composite endpoint was better. What is the composite endpoint? Reduction in HbA1c, reduction in blood pressure, reduction in weight without increasing risk of hypoglycemia. So that was the crux. So the combination of SGLT2 inhibitor and GLP has got the ideal combination, near ideal combination of oral anti-diabetic agent, and that has been proven in a real world study also, in which the SGLT2 inhibitor DAPA is being added to the existing GLP-1. That is the reverse start. So in this reverse start study also there is benefit. And the another real world study in the elderly patient, age more than 65, again the same result. So across the age the data is same. So let's discuss whether sequential start is better or simultaneous start is better. So you can see here in sequential start there is greater reduction of HbA1c. Simultaneous start there is greater reduction of HbA1c, weight and systolic blood pressure, while in sequential start there is less effect. But the point is, if you are starting both agents simultaneously, the adverse effect is more. The chances of hypoglycemia is more. The acute kidney injury is more. So for the simultaneous start, though the effects are more, the side effects are also more. But the sequential start, they are better tolerated. But of course, at the cost of reduced efficacy. So meta-analysis of the SGLT2 combined with the GLP-1 receptor agonist. Here the data from the award 10, duration 8, sustain 9 was combined. And again, the pooled data has got similar result. And there is reduced body weight, the fasting blood glucose is reduced, but the risk of hypoglycemia is increased. So no doubt the combination is efficacious, but the risk of hypoglycemia is more. So probably we have not reached the ideal oral anti-diabetic agent. Probably the GIP combination with the GLP-1 would have been a better choice. And now it is available, and the triagonist or the other agent we are coming with the in market, the GIP and GLP-1 combination, that may solve the problem, and that may be hitting something near to the oral anti-diabetic agent. So that is the point. So not only this, in patients who are having heart failure with reduced ejection fraction, since we are in the meeting of the cardiologist and most of the surgeons are also here, even the combination of GLP-1 receptor agonist and SGLT2 inhibitor, if they are given to the patient who are having heart failure with reduced ejection fraction, the combination is doing better as compared to monotherapy. So this is the very important point which we are heading towards, and maybe it will come in the recommendation in near future. So the best combination which can be used in heart failure with reduced ejection fraction is the combination of GLP-1 receptor agonist and SGLT2 inhibitor. So what are different points? If you are starting SGLT2 inhibitor, clinical pulse, the SGLT2 inhibitor, if you are starting, modify the loop diuretics. Always look for the symptoms of diabetic ketoacidosis. Always teach your patient about potential genitomycotic infection. And for the SGLT2 inhibitor, don't forget to stop the DDP4 inhibitor. I have seen the prescription, the combination of DDP4 inhibitor with this. So the combination is not ideal. So not only this, you have to examine the retina. So before writing SGLT2 inhibitor, you should rule out the retinopathy, particularly if you are interested in using semaglutide. So this is one thing. So key takeaway, summarizing all the crux from the talk, both SGLT2 inhibitor and GLP-1 receptor agonist reduces weight, BP, stabilize the EGFR, control blood glucose, and with the slight increased risk of hypoglycemia. Because cardiorenal protective property of the both agent, they are preferred drug in type 2 diabetes with comorbid condition. The GLP-1 receptor protects heart by anti-atherosclerotic property, while the SGLT2 inhibitor is predominantly used for heart failure patient. And SGLT2 inhibitor are renoprotective, like CANA. Now DAPA CKD trial is also available. So CANA and DAPA, there is evidence available For GLP-1, the best renoprotective agent is Dula, then Albu, then liraglutide. For the beneficial effect, both in terms of cardio and renal, they are independent of weight, HbA1c, and microalbuminuria. So this is very important. So renoprotective and cardioprotective effects are independent of weight, HbA1c, and microalbuminuria. So pleiotropic effects are very important. The alternate fuel ketone and decreased sympathetic tone is very important for the SGLT2 inhibitor, while anti-inflammatory and lipid lowering properties very important for GLP-1 receptor agonist. The genitourinary infections are common in case of SGLT2 inhibitor, while proliferative diabetic retinopathy is important limitation for GLP-1 receptor agonist, apart from the pancreatitis. The BP lowering effect of SGLT2 inhibitor is more pronounced. So if your patient is hypertensive, better to use SGLT2 inhibitor than GLP-1 receptor agonist. The combination of GLP-1 and SGLT2 inhibitor is well tolerated and have additive desirable effect. The simultaneous start is more pronounced effect than sequential start, but less tolerated. The Cana and dulaglutides are better agent for the sequential start due to GI adverse effect. The liraglutide and DAPA is better tolerated for the, and they are better agent for the simultaneous start. Okay. So thank you very much. So learn from the yesterday, live from today, hope for tomorrow, but don't forget to ask question. It gives you insight of the learning as well as it will give insight for a presenter also. So happy to answer the question, if any. Hello.
Just wait, Ashutosh. Dr. Sanjay's.
So I think this is an area which is coming up into the future, and it is very useful for the primary care physician as well as for the endocrinologist and cardiologist, since it is spanning around the across the spectrum of the specialty. It's also important for the nephrologist also.
Dr. Ashutosh, there was a glitch in network. So, Dr. Sanjay, who is actually moderating the session, will be asking questions. I'll just put him on from my link. Okay.
Okay. Okay.
Hello.
Yes.
Hello.
Yes.
Are you able to hear? Are you able to hear?
Definitely, sir.
Yes,
Dr.
yes.
Ashutosh, I want to, first of all, I want to congratulate you for your wonderful presentation. And we have few questions from you. And the
Yes.
questions is also from the floor and various people from the audience. So my first question is, SGLT2 inhibitor is getting a lot of buzz because of DAPA heart failure trial.
Yes.
But what is your views in terms of the future of SGLT2 inhibitor in the patients with the heart failure?
So, sir, actually, the heart failure is very broad term. So, heart failure with reduced ejection fraction is one where the DAPA HF trial was there, and now the Emperor trial is also available with the EMPA. The ARNI is already established agent. There are trials with the uh, bisoprolol and ibabradine, already established drug. The mineralocorticoid receptor agonist is also a drug in this area. So there is lots of heterogeneity existing in this area. So if you are talking about the heart failure with reduced ejection fraction, certainly this is a disease where you should use the established agent in the appropriate dose. So probably the ARNI is the first drug which we should use in these patient. And to to cover the residual risk, you can go on to adding the SGLT2 inhibitors. So combination of ARNI and the SGLT2 inhibitor is going to produce more result, provided you are able to introduce it properly with a proper dose and educating your patient about the uh, titration of the diuretics and avoiding the genitourinary infection. So certainly I am seeing a good future if you are using these two drugs in a combination, particularly in case of diabetic patient. In case of non-diabetic patient also, if the patient is elderly or patient is female, patient is having heart failure with mid-range ejection fraction, probably the combination will do better as compared to one drug. So for heart failure with preserved ejection fraction, there is a deliver trial for the SGLT2 inhibitor which is already going on. Only the result from that trial is going to solve the uh, going to answer this question. But one thing is very sure, since heart failure with preserved ejection fraction has got very heterogeneous etiology, as Dr. Ajay Pandey has already pointed out, we are unlikely to get any conclusive results. Suppose we get something very conclusive, that will be a very good thing. So my practical point is, if you are using these two agents with the appropriate modification and teaching to the patient, certainly these two drug combination can do wonder.
Right. Now I have another question. This is about GLP-1 receptor antagonist. So why do you think in India GLP-1 receptor antagonist is not as popular as SGLT2 inhibitor? What may be the reason for that?
Sir, the most important reason is the injectable therapy. Injectable versus oral. Since SGLT2 inhibitors are oral, these agents are injectable. Most of the time, patient refuse this, that I'm not going to take the injection. Second important point is the cost. The GLP-1 receptor agonists are more costlier than the SGLT2 inhibitor, and now SGLT2 inhibitors are available at very low price also. So certainly the cost is one issue, and another thing is the injectable therapy. Apart from these two reasons, another point is the GI adverse effect, nausea, vomiting. These are common with the GLP-1 receptor agonist, and if the patient is having diabetic gastroparesis, it can lead to very adverse GI side effect. So these are few limitations with the.
Regarding this side effect, as you mentioned, so which GLP has the lowest side effect, like nausea, vomiting, and diarrhea, as you mentioned? So do we have any particular type of GLP-1 receptor antagonist which we should prefer over the other one?
So what my thinking is, if you are a good warrior, you will choose always appropriate weapon in the war. So that is one thing. So it is always customized. So suppose I am dealing with a patient who is having diabetic gastroparesis, I will like to choose the GLP-1 receptor agonist who are having short T-half. So suppose I am having a patient who is having increased body weight, certainly I will like to choose the agent who is causing reduced body weight and having better GI tolerability. So the point is, it is all customized. So still, if you want that your patient is having less side effect, start with the low dose, go slow, titrate it, educate your patient, follow it appropriately, then patient is going to tolerate this medicine. So the main point is just stratify it. First, rule out pancreatitis or insulinopenic effect. And second point is the diabetic gastroparesis. And third point, never forget to rule out diabetic retinopathy before starting GLP-1 receptor agonist if you are using semaglutide. Among the all GLP-1 receptor agonist, probably the liraglutide is one of the better agent. If you are starting this in a lower dose, it is going to be a better tolerated agent. Never ever start with the high dose long acting agent like dulaglutide. If your patient will having nausea and vomiting, it will last for another 2 to 3 days, and patient is not going to come back to you if you are in private practice. In institutional practice, I don't know whether they will come back or not.
So, Dr. Asutosh, that has been a very useful information. Question which compares the GLP-1 receptor antagonist with SGLT2 inhibitor. So, which one amongst these two you think works for reducing the HbA1c faster and to a greater extent? Because that is the one what we normally monitor when we are following up the glycemic control for these patients in the long term.
Certainly, sir, the GLP-1 receptor agonists are more potent than the other agent. It is having greater HbA1c reduction as compared to the SGLT2 inhibitor. But the point is, if you are using Cana at the 300 milligram dose, the HbA1c reduction may go up to 1. But if you are using these GLP-1 receptor agonists, the HbA1c reduction may go up to 1.5, 1 to 1.5. So they are a very good agent in terms of HbA1c reduction. But again, the main point is the GI tolerability, the other issues which you have to take care before starting this agent.
Dr. Ashutosh, I have one question. That where will you rate, combination of DPP4 inhibitor and SGLT inhibitors compared to, the part which you took into this GLP-1 receptor agonist and SGLT?
Yes. So this is very good question, sir. Again, the DPP4 inhibitor, as it is acting predominantly on the postprandial part, and the SGLT2 inhibitor, they are also acting on the postprandial as well as fasting. The combination is very good combination because it reduces the genitourinary infection, and now the combination is also available in the market. But the point is, as a cardiologist, if you are looking into the patient who are having significant residual cardiac risk, certainly you want an agent which reduce the cardiovascular outcome as well as the renal outcome. So for both cardiovascular outcome and renal outcome, the data are sufficient, and they are superiority data for the GLP-1 and for the SGLT2 inhibitor. So the combination of GLP-1 and SGLT2 inhibitor are certainly far better than the DPP4 inhibitor and the SGLT2 combination.
Okay. Dr. Asutosh, this is a last question from you.
Yes.
This is, that we commonly in India, we use the SGLT2 inhibitor for these patients now. So, which SGLT2 inhibitor you think is better for a patient who has a diabetes and they have a established cardiovascular disease?
Sir, the main point is nobody want to solve this question because we need head-to-head control trial to solve this question. So unfortunately, there is no head-to-head trial in this regard. But let's compare one by one and try to have a conclusion in this regard. The AMPA is one SGLT2 inhibitor which is having a significant data for the heart failure in diabetic as well as non-diabetic patient. It is a drug which is having some anti-atherosclerotic property, while other SGLT2 inhibitors, they are not having this property. But for primary prevention with patient having multiple risk factor, again the data is lacking, and in Emperor trial, the results with the multiple risk factor, the results were reverse. And in DAPA HF, we have seen that DAPA is better. So the point is, at this particular time, for DAPA, we have trial as a DAPA HF for both diabetic and non-diabetic patient. So for heart failure, primary prevention and secondary prevention, enough data is available for the DAPA. Second point is the renal protection. For the renal protection also, now the DAPA CKD is available both for the diabetic and the non-diabetic patient. The data is available for the DAPA, but for the primary prevention of the CKD, probably that data are not so strong. For the CANA, the point is it is an agent who have a capability to reduce HbA1c most, and it has capability to reduce weight most. So this is the agent which can be used for glycemic control as well as for the nephroprotection. And there is a substantial amount of data for the secondary cardiovascular protection. For primary prevention, again, the data is lacking. So comparing all the SGLT2 inhibitor at this particular time, when the data of AMPA kidney trial is not available, probably the DAPA is doing much better as compared to AMPA and CANA. But again, if you want nephroprotection with HbA1c reduction with weight loss, CANA is better. For non-diabetic patient having CKD and the heart failure, the DAPA is better. For diabetic patient who is having established cardiovascular disease, having reduced ejection fraction less than 30%, having atherosclerotic property, probably AMPA is better. So it is all customized. It depends upon which type of patient you are dealing with.
Okay, thank you, Dr. Ashutosh. I think that is a wonderful piece of information you have provided us. This is a last question which has come up from the floor. I just want to conclude with this. This is a practical question. If the patient is on insulin and you start the patient on SGLT2 inhibitor, should we withdraw the insulin completely and let the SGLT2 work, inhibitor work?
No, never. It is a rule that if you are starting SGLT2 inhibitor, don't stop insulin, because stopping insulin will lead to more predisposition for diabetic ketoacidosis. So for recommendation, it is there that if you are starting SGLT2 inhibitor, reduce the 15 to 20% dose of the insulin, and then you can monitor your patient and accordingly you can judge. But never ever stop the insulin altogether and give the SGLT2 inhibitor, because it may lead to disastrous consequences like genitourinary infection and diabetic ketoacidosis.
Thank you, Dr. Ashutosh. Now, I just want to ask from the other panelists, do you have any other question from Dr. Ajay Pandey or Dr. Ajay Belia?
I have got one question again. You have mentioned that GLP-1 receptor agonist and DPP-4 inhibitors combination should be avoided. So it's because of the pancreatitis effect or something else?
The basic point is the combination of GLP-1 and SGLT2 inhibitor, they can increase the chances of acute kidney injury. So suppose somebody who is having any problem like acute illness and volume depletion, and simultaneously both SGLT2 inhibitor and GLP-1 is started, there is a dip in EGFR, and that will lead to exacerbation of acute kidney damage. That is the biggest fear. And second, more important point is the GI side effect. Suppose if you are using CANA, which is having some SGLT1 action also, so it will have more GI adverse side effect, and you are using the dulaglutide, which is again a long-acting agent with more GI side effect, there is more chances of nausea, vomiting, and intolerability. So GI side effect and acute kidney injury is the most feared complication.
You said about some DPP-4 inhibitors and GLP-1 receptor combination has to be avoided.
Yes.
What's the reason for that?
Because both are acting by same pathway, that is the GLP-1. So suppose you are combining these two agents, this will lead to common pathway.
The risk of pancreatitis and other things also becomes high with.
Yes, risk of pancreatitis is high with the GLP-1 and DPP-4 inhibitor. So suppose somebody who is having a history of pancreatitis, the DPP-4 inhibitor and GLP-1 should not be given. Though the risk is minimal, but ideally you should avoid.
Thank you.
Right. If Dr. Ajay is okay with his answer, then do we have Dr. Ajay Belia? Does he have any question?
Nice to see Dr. Pandey sir in this COVID era. We are talking face to face. Nice to
Well,
meet
this is the
all.
this is the new normal, Dr. Astos. You know, this is how we will be talking for quite some time. You know, and so with this, I think I would like to thank Dr. Astos for his wonderful presentation, and thank you very much, Dr. Astos.
Thank you. It's my pleasure.
Now, I would like to pass it on to Harsh Ji from the Zydus and his technical team. And before that, I would like to thank the industry, Sanofi, Novartis, Alnich, Intas, and Zydus for their active and wonderful participation. And we look forward to their help in the future. And we really thank them. And we are really appreciative of their help. So I would like to hand it over to Harsh Ji for further comments and concluding remarks.
Right. So thank you so much, sir, for helping us out and for such a wonderful event, sir. We have got more than 350 viewers for the event, and the event was wonderful, sir. And I got some messages as well, sir, appreciation message of the event, sir. So thank you so much for your time and helping us out for making this event successful. And as always, sir, before we end any event, sir, at Zydus, we used to end any event with the national anthem. So I would like to play a national anthem at the end of this event, sir. So I'm going to share my screen now.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे जय
So thank you once again for all your support. Thank you so much.
Bye, Amit. Thank you very much.
Thank you, Ashutosh. Good night. And thank you, Harshji, and all company personnels for a wonderful evening, wonderful participation. Thank you, Ajay sir.
Thank you so much, sir.
Good night, sir. Good night.
Good night,
Thank
Dr.
you, sir.
Jignesh